and her team access our venue, we shall stand up because we shall be singing the anthems, okay? So we shall play the national anthem and the East African anthem, and thereafter we shall have a short prayer, and then we shall take our seats, okay? And then the session chair for the opening session will start guiding us on from that point, and that is the RDC Susan Akanyi. And like I said, in the opening session we have some speeches, and it will start by the director of the referral hospital, Dr. Lima, giving us an overview and the objectives of our first Regional Health Assembly. Thereafter followed by a statement from the CAO, the Chief Administrative Officer of Gulu City, and also welcome remarks from His Worship the Mayor of Gulu City as well. And we shall continue our official session with a statement from the Acting Deputy U.S. Mission Director, and followed by the Honorable Minister of State for Northern Uganda, and then our guest of honor, who is representing the Minister of Health, in the persons of the Honorable Minister of State for Health, General Duties, will also be with us here to officially open our assembly. When that is done, we shall now have our first keynote address by our keynote speaker for today. All that is done in this hall. So after the keynote address by our keynote speaker for today, that's when we shall break for tea and go down for a group photo first, then tea. So we shall get the spot. The photographers will direct us where we shall take our group photo, and then we shall break off for tea, and then immediately after tea, please go straight into your break room sessions, okay? Like I mentioned earlier, you have Elephant Hall and Ballroom Hall just on my left on this side. So you go straight in for that, and I request that the session chairs for those break room sessions must be strict on time for both the presenters and the question and answer sessions that they may have. So please ensure that you break off and maintain time. That's from about 11:30 to about 1 o'clock, because lunch is exactly at 1 o'clock here. And lunch is for 1 hour, and we shall again come back for the afternoon break on sessions. That means directly after lunch, go straight to the hall that you feel comfortable with. So there we shall again also have different session chairs for the afternoon. And like I said, time is of the essence for us, okay? Time is of the essence because we need to be down and out by about 4 o'clock today for today's session. Tomorrow, we expect you to be here by 8:30 latest, so that at 9 o'clock we start on time. Tomorrow is our second day and our last day. So tomorrow we shall have to be here by 8:30. We quickly finish our recap so that we start with the keynote speak for tomorrow. That is tomorrow at about 9:30 to 9:45. So that will be then handled tomorrow. But for today is our official opening and our break-off sessions thereafter. So ladies and gentlemen, anytime now, that will be done. Remember, don't forget the words of your anthems, please. We have the national anthem and the East African anthem to sing. And then we shall have a short prayer, and then we shall take our seats. Thank you very much. Hello, ladies and gentlemen. Please take your seats. Let's be seated. Let's get organized. Like I said before, ladies and gentlemen, this is our first annual Regional Health Assembly for Acholi sub-region, and we are under the theme of improving key health service indicators for host and refugee communities in Acholi region through sharing knowledge and evidence-based strategies to effectively and equitably optimize outcomes. And I can also mention to you that our guests are here with us, and our participants are basically drawn from the region. We have the DHOs, we have senior health colleagues here, we have commissioners from the Ministry of Health and other members from the Ministry of Health. We have our partners here as well, our implementing partners and our local partners. And we also have the RDCs, the leaders, the RDCs, the LC5s, the chief administrative officers, the mayor here with us. So ladies and gentlemen, it's a full packed house. Like I said, this opening session is here in this hall, and then later on we shall break out into the sessions for the presentations later. I would like us to remember that, as I had earlier mentioned, when our guests are in, we shall stand up, we shall sing the national anthem, and thereafter the East African anthem, and then we shall remain standing for a short prayer, and then I'll ask the session chair for the opening session, and that is, and sit up there and control the opening session. So ladies and gentlemen. Thank you very much. Let's have a word of prayer by Dr. Janet Owola, DHO Nuoya.
Let's humble ourselves in prayer. Almighty Father, we thank you for the gift of today, as we thank you for the gift of life. Glorious and blessed God, we place this meeting and everybody in this room in your hands. Anoint our creativity, our ideas, our energy, so that this meeting may yield fruit and may it bring you honor. Can you reign in us? And as we deliberate, Lord, give us the wisdom and understanding that we may be able to internalize whatever will be presented today and tomorrow for the betterment of the health of the people in this region. We ask you to bless our overall health administrators, our local administrators, give them discernment. Bless all our workers in this, and let this compassion be rooted in your love. May your face, God, illuminate the activities of these 2 days, and let us deliberate to the fulfillment of your glory. We ask all this in the precious and powerful name of our Lord Jesus Christ. Amen.
Please take your seats. Thank you. Thank you, Dr. Janet. Thank you for the wise prayer that you've given us. Ladies and gentlemen, like I said, here we are, about 50 or so participants physically attending this conference, our guests. But I can tell you that there are about over 200 of us in attendance right now virtually, and we shall maintain that number for these 2 days. So as you speak, do not look at yourselves, the ones who are here only. There are about 200 other people attending virtually. I would also like to call upon the RDC, Susan Akany, RDC of Agago, who is the session chair for this opening session, to take your seat up there, please. And We shall have our speeches, we shall have our speeches now. And briefly, she will be bringing in, yes. Session Chair, you're welcome. And like I said, we have started just slightly bit below time, over time, but we shall try and catch up as we go along. So Session Chair, the speakers are there with you, the program is with you. You introduce the speaker, and they'll come and speak to us. The floor is yours, Madam. Probably she should. Is there a mobile microphone? Or she should sit up? No, there is a. Can you get a mobile microphone, please? Cordless, as they call it. Okay.
Thank you so much, our MC, our Honorable Minister for Northern Uganda, and all our invited guests. You are most welcome to the first ever Acholi Annual Health Assembly. Thank you so much for coming, and thank you for turning up. And I would also like to recognize our virtual participants. You're most welcome. I would like to take this opportunity to invite our first guest, the Director, Gulu Regional Referral Hospital. You're most welcome to come and speak to us.
Honorable Minister of State for Northern Uganda, all the invited guests, our guests who are virtually with us here, not physically with us, the media fraternity, ladies and gentlemen. Mine is a brief presentation on what has been happening the 2 days and what will happen in the next coming 2 days. We had a joint review for the last 2 days. The third day, today and tomorrow, will be the Health Assembly. Honorable Minister, this is the first of its kind in Uganda, not only in Acholi, that we are holding a regional health assembly. And basically, before going into my presentation, we are just going to present a voice. The voice in terms of numbers, the voice in terms of other figures, and the voice of other people. Basically, we can sum that it is a voice which today we are listening to. What the partners have been doing, what the ministry has been doing and taking lead, and what the regional referral hospital has been doing, and what the local governments have been doing. Honorable Minister, we have this is a stakeholders meeting preceding the 2 events of joint review meeting. We expected the Parliament to be represented here by the Right Honorable Speaker, but I think we have not yet gotten back from, he has not gotten back to us. We also expected Honorable Minister for Northern Uganda. We also expected the Honorable Minister for Health, which delegated the Honorable Minister for Health, Minister of State for Health, General Duties. She will be joining us shortly. We also expected the chairperson of Acholi Parliamentary Group and the members, the honorable members, because I say this is a voice. We are passing a voice. Honorable Minister, the lead has been taken by Ministry of Health through Gulu Regional Referral Hospital. Then the support has been from the partners. We are taking lead in doing this. It's not the partners taking lead. We organized this through our Department of Community Health deliberately so that we can reach the entire region. Our aim now is, the ministry's aim is that everything done in the health sector must go through the regional referral hospital. Can you go back to the previous slide, please? These are my slides, they are not yours. Go back until I tell you next. Is that okay? So that's why, Honorable Minister, we invited the local government leadership, the LC5 chairpersons, the chief administrative officers. We also invited the persons running the district health services, headed by the district health officers. And then we also invited the municipal health services. You can see I put municipal in inverted commas because there is no law gazetting a health officer for Gulu City. Remember, there is only one act which is available, which is the KCCA Act. The other acts are supposed to be passed. We also invited the faith-based organizations. These are church-funded institutions. Our great partner and friend, St. Mary's Hospital, Acholi. We also expected persons from Kalongo Hospital, Kitgum Hospital. If they are not physically with us here, they are virtually with us. Then we invited the development partners. I've seen WHO, I've seen UNICEF, USAID, and so on. We also invited partners working with health. Rights North Acholi, which has been a very great partner to us. They will have a voice, I think, in the course of the week to tell what they have been doing and what they have achieved. Honorable Minister, we also invited the training institutions. Remember that your backbone in these health services lies in the training institutions. I want to elaborate a bit here, especially Gulu University. I have one obstetrician. Gulu University gives me 3 obstetricians. I have 2 surgeons. Gulu University gives me 3 surgeons. I actually ride on the back of Gulu University. That is how we have been running the health services here. That's why I say these are voices. The voices with time you will pick and record. We also have College of Health Sciences, the one which trains diploma holders, and then St. Mary's Hospital Acholi again has a training institution for nursing school. Next. Honorable Chair, we did not forget the community, the communities and the partners working in the community, especially the local NGOs. We also invited private for-profit organizations who are dealing in health. They will also have a voice and what to say. Then we also invited the complementary medicines organizations. These are people who have been put in law recently to provide health services in the country. Honorable Minister, we want to communicate issues post-war recovery. War has been 20 years ago. We can't continue and begin speaking of war, and so on. So where have we been? Where are we now, and where will we be? That is basically going to be what is there in the communication of the next 2 days. Honorable Minister, we also want to know, we want the members to know the Ministry of Health's stake in this region, especially on issues of overall supervision, coordination, and resource mobilization. These resources are not only funding resources, including human resource. We want to begin seeing if we can, because it is already happening. Ministry of Health is posting consultants into PNFPs and supporting them with wage. Ministry of Health also supports PNFPs with funding. So can we start posting in local governments? Because the issue is, we want to sum up how we can handle health services in this region. Then, of course, other oversight functions. Then we want to bring in the regional referrals of hospitals stake. Honorable Minister, our interest is to expand the community health department. The structure has been passed by public service, so we shall have specialists put under the community health department. Some of these specialists will have to be posted to the hospitals. So, Honorable Minister, that is now where we are, where we want technical supervision and supportive supervision to the regions. Not only mentorship, we really want technical supervision, where we can train people, where we can make people confident. One of the biggest reasons, Honorable Minister, why doctors cannot take up places in Health Center 4s and Health Center 3s is because they are not confident. They are not. All the referrals are brought to Gulu Regional Referral Hospital. Very simple operations. But you have 2 doctors. There is a facility I will not mention. They had 2 doctors here in Gulu and 2 anesthetists. In the last 7 years, 2 years, they did only 7 scissors. This hospital does, on average, 18 to 25 scissors in a week. Where is the wage redundancy? That means we are paying somebody free money. So these are the discussions which must come up clearly and as a resolution. I will still present it tomorrow. Honorable Minister, there are new insights in a policy environment. The emergency medical services, the Cancer Institute, and the rehabilitative services, which are palliative services, which are coming in the region. We also want to have a voice. There is a presentation on that, I think tomorrow, by the Commissioner of Emergency Services. We want to put it to the leaders, especially the elected leaders in local governments. How exactly will this EMS operate? And it is a very good service, but if we don't handle it well, it will backfire on us. Honorable Minister had already talked about placing human resource for health in local governments, especially specialists. Preferably, we start with maternal and child health. The Commissioner of Clinical Services is around. He will also, maybe tomorrow, present on that issue. Next. That is the objective. If you read through all this, it is just the voice of the people. Which voice are we presenting? The first statement I made. So the joint review and the annual performance of the regional and district health sector. Where are we? Where have we been? And where do we want to go? Then to discuss the purpose and mitigation measures for the health sector performance. What are the bottlenecks? And how can we avoid these bottlenecks? Usually when I teach students, I rarely ask for challenges. I want you to be very innovative. You can even do Caesar under the mango tree. Is that okay? Yes. You can amputate under a mango. In Somalia, are you UPDF amputating in a national hospital? So, can we do things with what we have? I'm not saying that let's go and work under a mango tree. We have facilities. Why aren't we using it? Do we want to upgrade the facility first before we use? So those are some of the issues we shall discuss in the next few days. Then to share lessons and practices And even benchmarks which have been right in the health sector. Some districts are performing very well, others are not. Take the COVID, the recent COVID. There are districts which are not achieving immunization. They will tell us why they are not doing it. And then also to establish networks and with other regional stakeholders. This being the first of its kind in Uganda, I think the other regions will take it up. And I still believe this should be the one which should feed into the National Health Assembly, so that we go there with the refined objectives, with the refined, how do I say, what we want to achieve. Is that okay? What we want to achieve. This is what the Acholi sub-region wants. This is what Karamoja region wants. This is what West Nile wants. Is that okay? So that should now feed into the National Health Assembly. Next. Thank you very much. I've put those words there. Afoyo Matek, you should know it is across the Nile. Ward 4 is across the Nile. Alakara is northeast. Alakara Noi. Manjora is just next door. Wevalenyo. For those of you who don't know other languages, sorry for you. Thank you. May God bless you, Honorable Minister.
Just a minute, Session Chair. Just something to guide us. The pinging sound you're hearing is by us who are here going online. You're here, but you want to also be virtual while here. So they're saying if you decide to go online, please mute it, because that sound will keep on reverberating here for us. And then also another thing is they're saying limit your movements. The ones who are watching us are seeing us more walking than listening. So please try and limit your movements when you're inside here, okay? Even if you may think you're in some corner, we are seeing you. So please try and limit that. So when you're going online here, please keep it muted so that it doesn't give us this feedback. Is that okay? Session Chair, please. Oh, where's our mobile mic, our cordless mic? We need that mic with the chair. Yes. Actually, it is fixed at that point.
Thank you so much, our Director of Gulu Regional Referral Hospital. Thank you for giving us the overview and the objectives why we are here. So now we know why we are here. Thank you so much. Can we applaud our Director? I always don't like to summarize what has been said. It irritates, so I'll not do that. Can I take this opportunity to invite Kaogulo, Mr. Geoffrey Okaka, to give us a statement? Kao, you're welcome.
Honorable Grace Freedom, the Minister of Northern Uganda, our host, the Deputy Mayor, the entire Minister of Health team, the resident City Commissioner, the resident District Commissioners of Acholi Region, the District Chairpersons, my colleagues, the Chief Administrative Officers, the Secretaries for Health, the District Health Officers, the cultural and religious leaders, members of the donor fraternity, implementing partners, Right North Acholi, UNICEF, World Vision, Enable Uganda, TASO, Human Rights International, Youth Alive, UN agencies, to mention but a few. All invited guests, the members attending virtually, ladies and gentlemen, good morning. Okaka Geoffrey is my name. I'm the Chief Administrative Officer of Gulu District, and I stand here to warmly welcome you to this first Regional Health Assembly, where we come to review the activities done and we acknowledge the challenges so that we gauge how we can move on. I again come here to remind us that COVID-19 is still a challenge, and Gulu is the hub of the region. So when you are here, I need to remind you that you need to take a lot of personal care about yourself while at the venue and even when you are outside this venue. The theme of this assembly has been well crafted: improving key health service indicators. Improving key health service indicators, which to me is acknowledging the fact that this is still a journey. This is still a journey, and we, while moving through the journey, should improve. We implemented activities in 2020-2021, for which we now come here to assemble and review. And among others, we conducted joint support supervision visits. We also held district performance review meetings quarterly, and also accounted for the funds government and partners gave for service delivery in the health sector. Now we assemble here to look at our best practices and also challenges, and also we get how we can improve as we move on in 2021, 2022 financial year and other coming financial years. Just to mention a few in terms of best practices, we would like to acknowledge the fact that Ministry of Health as a line ministry is supporting district local governments. This is a fact, our guest of honor. We also acknowledge the fact that the ministry gave transport facilities to some local governments, and we have hope that those local governments which did not have will still get. We also acknowledge political support and will. Honourable Minister, your presence here amidst your schedules and also the presence of these guests is acknowledging the fact that you are together with us in this journey, and we can't take it for granted. We, as a best practice, also acknowledge commitment from service providers and our partners. I've mentioned them as I was opening, and they are here with us, and we can't take it for granted. We also timely report to the ministry, and in the district local governments, municipalities and the city, there is teamwork as a best practice. And with support from Enabel Uganda, we are having our health workers motivated because of results-based financing. Indicators have been put, and units which achieve those indicators are rewarded, and it is a good incentive to our health team in providing health service to the people of Acholi sub-region. We also have joint integrated implementation of sexual reproductive health, HIV, and gender-based violence interventions. We also have a functional maternal death review team. Each time death occurs in the course of delivery, in the course of birth, there's a team which does an audit, and this is reported to the Ministry of Health. We are also observing standard operating procedures, of course, acknowledging the fact that COVID-19 is still a challenge. I thought I needed to mention those best practices to you, our guests, and also to the participants. But amidst all this, we still have challenges. Amidst all this, we still have challenges. We are still having staffing gaps at the district level and also at the health facilities. Just to mention, but you can acknowledge the fact that Gulu does not have a district health officer substantively appointed, and I've been briefed that the same applies to Kitgum, the same applies to Pade, the same applies to Lamour. And this is a big challenge, partly occasioned by the fact that the two immediate assistants to the district health officer do not have the requirements of a district health officer. And this is a structural problem which needs to be reviewed. And it is making obtaining district health officers a challenge. Some of our structures are also in poor shape. The general ward, the outpatients department, maternity and staff houses need attention. We still also have challenge of drug stockouts. We still have the challenge of upsurge of malaria in the region. I've already mentioned COVID. We still have some sub-counties without health center 3. Transport still remains a challenge, as well as functionality of some health center 4s. And again, Gulu has transitioned. We were initially more or less an urban district, but now we are we acknowledge the arrival of our guest. I was saying that Gulu was initially more or less an urban district, but now with the coming of Gulu City, we have become a rural district. The referral now sits in the city. Our highest level of health facility is Health Center 4, which is a watch, and we look forward in transiting a watch from Health Center 4 to hospital as per policy, and that still remains work in progress. Again, as a challenge, we need to continuously focus on the safety of our health workers in the course of duty. As I conclude, in terms of recommendations, we still need wage provisions for filling of vacant posts in the health sector. We still advocate for more funding to improve on service delivery. We still advocate for increase and recommend that credit line drug budget be increased, and that we focus on malaria intervention and joint integration of programs. We also recommend that the regional task force for COVID-19 for Acholi region be supported and be operationalized. Again, as a region, we pledge to continuously improve, as the theme suggests. We pledge to continuously improve. And once again, I thank you for your kind attention. Thank you so much.
Thank you so much, our cow, for that great presentation. You're most welcome, our chief guest. I'm Susan Akany, Resident District Commissioner Gago. I'm the chair of this session. Welcome. I would now like to take this opportunity to welcome our mayor of Gulu City to make a statement. Mayor, you're welcome.
Hello all. Honorable ministers, the RDCs and the RCC for Gulu City, the LC5 chairpersons present, the chief administrative officers, all executive officers from the Ministry of Health, our developing partners, all the training institutions represented here, the media fraternity, ladies and gentlemen. My name is Christine Olok. I am the Deputy City Mayor of Gulu City. I greet you all and warmly welcome you to Gulu City for this momentous occasion on the first Regional Health Assembly for Acholi sub-region, which goes by the theme, improving key health services for host and refugee communities in Acholi region, through sharing knowledge on evidence-based strategies to effectively and equitably optimize outcome. In a special way, allow me thank the partners, that is the USAID, the Gulu Regional Hospital, Annabelle, UNIPs, and the entire Acholi region for supporting this initiative and choosing Gulu City, which happens to be the regional city for Acholi region, as the host to this important assembly. And for that matter, the first of its kind. We thank you very much for choosing this region. With these few remarks, Gulu City Council wish you all a wonderful deliberation and a safe stay in Gulu City. I thank you very much. You're welcome.
Thank you so much, our mayor. I think that's not enough. Let's give a big hand clap to the mayor. Thank you for welcoming us. I think my session ends. Okay. I'm told to continue. I have another Kisanja. Thank you so much. I would like to know whether the next presenter is in the house.
Session Chair, our next presenter is online.
Okay.
Acting Deputy U.S. Mission Director, Tim Stein, is online.
Thank you. Thank you. Our next presenter, the Acting Deputy U.S. Mission Director, Mr. Tim. You're most welcome to present to us. I'm happy that you've joined us online. Thank you so much.
Tim is listening. Can he unmute himself? I know he's listening to us. He should set up his system, unmute himself, and he will be connected here with us. He cannot unmute? Is he listening to us? Can we call him direct on his phone probably? Or he's online?
Good morning, everyone. Can you hear me?
Yes, we can. Yes, we can. Go ahead.
Good. My sincere apologies. The administration of Zoom was blocking being unmuted. My apologies, everyone. My name is Tim Stein. I'm the Acting Deputy Mission Director for USAID. Honorable Minister of State for General Duties, Honorable Minister for Northern Uganda, Honorable Members of Parliament, local government leaders, Ministry of Health officials, partners, distinguished guests, ladies and gentlemen, all protocols observed. Good morning. It is my pleasure to be with you, albeit virtually, on this momentous occasion, the first ever annual Regional Health Assembly for the Acholi region. I congratulate the Gulu Regional Referral Hospital and all partners for organizing this health assembly. In these challenging times of COVID-19, I believe this assembly will help us find local solutions for the communities we serve. The United States is proud to be associated with efforts to improve access to and quality of health services across the 8 districts in the region, serving 1.8 million Ugandans and about 54,000 refugees hosted in the Lamboa district. Over the last 2 decades, the United States, through USAID, has led many projects to strengthen the health system and ultimately lead to greater access to affordable quality health services in the Acholi region. One of them is Rights North Acholi, which is a 5-year, $58 million program that enhances the capacity of health districts to apply proven best practices across HIV, tuberculosis, maternal, newborn, and child health, reproductive health, family planning, malaria, nutrition, and water, sanitation, and hygiene services. Through Rights Acholi, we have provided technical, operational, and human resources support to the Gulu Regional Referral Hospital in its oversight role in the region. Our next planned step is in the partnership. Our next planned step in the partnership is to provide a grant directly to the hospital after a comprehensive financial assessment is conducted later this year. During the last 4 years of work under Rights Acholi, USAID and partners have seen sustained improvements in access to health services, including a 37% increase in the use of the outpatient department, the doubling of the amount of births delivered at health facilities from 2017 to 2021, and the reduction of maternal mortality to less than 80 per 100,000 live births, surpassing the national target of 98 per 100,000 live births. More than 97% of people living with HIV in the Acholi subregion have been provided with testing services to know their HIV status. Of those who are HIV positive, 97% are on treatment and 91% have achieved viral suppression. Our partnership has gone a long way to improve human resources information systems. When the activity began, only 5 of the 8 districts in the Acholi region had a functional and up-to-date database to track health facility staff attendance and absenteeism. Now, all 8 have their systems up and running. Staff absenteeism has dropped from 18% in September 2020 to 7.3% in June 2021, despite the COVID-19 challenges. The U.S. mission has also partnered with the Belgian government to implement results-based financing in 4 districts in the region. Over the last 2 years, this collaboration has yielded positive results, especially in the areas of maternal and child health and nutrition. The quality of reproductive, maternal, newborn, child, and adolescent health care across the supported sites has improved from 70% in 2019 to 86% in 2020. Together with the district teams, the U.S. has been instrumental in supporting the COVID-19 pandemic through case management, surveillance, laboratory diagnostics, risk and behavior change communication, infection prevention, waste management, and vaccine distribution. The U.S. government is moving towards having direct agreements with Ugandan organizations to implement programs. In this regard, we have awarded the Ugandan Protestant Medical Bureau to lead technical support for HIV and TB services in private, not-for-profit facilities in the country. The AIDS Support Organization was recently awarded a $35 million 5-year grant to support HIV and TB activities in Acholi and Acholi regions for the next 5 years. Although there is still work to be done and improvements to be made, it is evident that the work we are all doing together is having an immense and enduring impact. The U.S. government looks forward to continuing to partner with the government of Uganda, civil society, and many development partners to address the health challenges affecting the Acholi region and Uganda as a whole. Thank you for your time this morning, and I hope you have a constructive and productive assembly. Thank you.
Thank you so much, Acting Deputy U.S. Mission Director, for that presentation. And thank you for the great support to Acholi sub-region in particular and the country at large. Thank you so much. Is that how you clap to your biggest partner? Thank you. I would now like to take this opportunity to invite our Minister of State for Northern Uganda Rehabilitation, Honorable Grace Freedom Kwechwiny. Honorable, you're most welcome to talk to your people. Thank you. Thank you, the MC, for today, the Minister for Health, the Minister of Health, our friends to Northern Uganda, Miss West Nile. If you didn't know, I have to begin telling you some of these things. And soon, going to be crowned Miss Northern Uganda. And when I say that, you know that it's not for nothing. It's for her passion, which is not just starting today when she's Minister of Health, but it's a long story. And I'm so happy to receive you here today in Northern Uganda, together with your team of technical people, of policy analysts, and this meeting must make a difference today in Northern Uganda. The development partners, and I want to recognize the U.S. mission team represented by one of our key presenters this morning, the RDCs, the COWs, the chairpersons LC5, the mayor, and all of you technical people and political leaders. I'm happy to receive you to Northern Uganda. And I'm happy I'm hearing that this is the first regional health assembly, even in Uganda, not just in Acholi region. But I want to recognize that I think it was 2016 or 2017, there was a regional health assembly in West Nile, in Arua. And they told us there was a similar something happening in Western Uganda. And they told us those 2 regions were pilots. And so today, when you say this is the first of its kind, I want to think that the pilot was successful. That is why we are able to now host the first regional assembly in Uganda. But I also want to report that since the first meeting I had in Arua, there have been other regional assemblies, and I don't know who has been organizing it. At least in West Nile, it has been taking place, but I think not to this extent. Now today you launch it, and it's a good practice, I must say, and it's a practice that must not end here. That must be frequent, that must take us to the next level. I want to congratulate Ministry of Health for that. I want to congratulate the ministry, especially when the planning like this bring in many people. Some time ago, a lot of planning is done at the ministry and then it's brought at the district. But now this is bringing us, even the lay persons, even the victims, I should say, because you here are professionals, you are planners, you are policymakers, but we the sick people who do not know what happens when you are planning, when you are budgeting, are also here. And so it is good for us to tell our side of the story, and I want to support this theme, which is talking about refugee communities and host communities. This is us. This is us, and we are able to talk in this forum. I'm so happy. From the northern Uganda perspective, I heard the doctor talk about the overview, and we are also emphasizing post-war recovery. I think this is a spot-on emphasis to put. Because from the post-war, or from the wars, we have had so many challenges. Accessibility social services, health being a priority, has been a problem for us. Walking distances has been a challenge to us. And I want to congratulate the Minister of Health again, that just last month, we were launching, we were groundbreaking for a cancer institute, also in this region. And so we think our accessibility is improving slowly, and it should address all our challenges. We, the people, are poor. The recent National Housing and Household Survey shows that Acholi region poverty indicators has risen from around 33% to 68%. And that means a lot in health. That means these are the poor people, and a poor person is a sick person. A poor person is a hungry person. A poor person is maybe even stunted because he is not eating enough and also balanced diet. A poor person is the one who will miss school, who will miss class. And so a poor person is an illiterate person. So now when you bring health in, this now is even taken to higher heights that we may not be able to access these facilities and services if you are poor. And so when you are talking about post-war recovery, where are we, what are we doing, and how can we plan better? I think we have to take this into consideration, that our population is still poor, and a poor person has a lot of challenges. One of the reasons which may explain the level of poverty is the nodding disease, which has been here for a while. And I know the Minister of Health has been working with this, has been planning with this, but it is still with us. The victims are there, the families are there tied with them, they cannot work, they have to look after this girl, this boy. The good thing is that we are not getting new cases. I hope I still I'm relevant here. But those cases are still there in our communities, and we need support. And this is an area I would like my sister with your technical team, if we can address the medication and other related factors with them, I think this would be a good thing to do. So in northern Uganda, we have been discussing development. How can we get out of poverty so that we can enjoy all these facilities that are coming? Education, health, water, with a meaning. And for a long time, we would like to even transform our lives so that we can have the socioeconomic empowerment and we can improve our livelihood. When we improve our livelihood, we shall be healthier, we shall be able to understand the facilities, we shall be able to plan together with everybody for what can benefit us. And so I want to thank you, and I want to recognize everybody who has come, but also in a special way, I have been requested to recognize our partners. My sister, I think I can do this on your behalf as well. These are your partners you have worked with for a long time. USAID and her associates, I think they must be represented here. The UN agencies, that is World Health Organization, UNICEF, UNFPA, they must also be represented here. URC, URM, CHIP, Planning, Financing and Policy, and SCAP departments, the Belgian Development Agency, that is ENABO, MRF, Health Africa, Johns Hopkins University, particularly the Center for Communications Program, Uganda Protestant Medical Bureau, Gulu University, especially the COVID-19 testing laboratory. I think it makes it easy for us and more accessible to address the COVID issues. Gulu Regional Referral Hospital. If I have not recognized you, it means this list is short of that information, but feel pleased to be here. And I would like to thank you so much for coming. And all the districts, the local governments, and the city, we should never be the same again after this meeting. With all our brains I'm seeing in this room, we should never fail. Honorable Minister, it's my pleasure now to take this opportunity to once again welcome you to Northern Uganda, but also specifically to invite you to address this meeting. God bless you.
The Honorable Minister of Northern, now Miss Black. The Honorable Minister of Northern Uganda, members of Parliament, present here, in case you are around, the acting USAID mission director, all our partners, development partners present, and those online, our mayor, who has been here represented by our good lady deputy mayor of Gulu City, the chairperson of all the district resident commissioners, the district chairpersons from the sub-region, all the other DCs in their different capacities, religious leaders present here, the Ministry of Health directors present here, Dr. Acholi and your colleagues and commissioners from the ministry, the director of Gulu Regional Referral Hospital and all their technical staff, our chief administrative officer and all our technical staffs present here in your different capacities, all the implementing partners who are present and online, all those that are within the HRSS system and our front liners present and online, the media, ladies and gentlemen, all protocol observed. I want to bring you, first of all, greetings from your sister, from your daughter, from the Senior Minister of Health, Dr. Jane Acheng. She has not been able to join you today, but she's with you and participating because of other pressing urgent matters within the ministry. She, however, wishes you good deliberations, and as the minister has said of the northern region, she's so hopeful that after these deliberations and all the knowledge or what we are going to share out today, the sub-region and the entire region will not remain the same as far as health service delivery is concerned. She affirms her participation and cooperation to ensure that the resolutions that will be reached at this assembly, the Ministry of Health will take them with keen interest and address them. I'm delighted again to say that I want to thank the government for its focus towards development and service delivery in the northern region. I'm so glad that the government of Uganda, under the stewardship of His Excellency the President Yoweri Kaguta Museveni, Tibuhaburwa, thought it well that it's high time that attention was given or directed to development and quality service delivery in this region, the northern region, and more so service delivery which is qualitative in the health service, the reason we are all here. And I want to thank the government and the president for having focused and ensured that this is not only on paper, but for having once again reappointed my sister, who is a run-up in the beauty contest now in the western region, in the northern sub-region or the whole northern region. So her reappointment, not many were appointed or reappointed, but to see that she was reappointed to be in charge of northern region, a region which is not small, by the way, and the entire region, that means that her performance was very, very excellent, and I want to thank you so much. This is my second time I'm here, since I was appointed, and have not missed you here on board. And I've been also, as we share out, you have put in all your efforts to ensure that you do your work or execute your work as per appointing authorities' expectation. I wish you well, and I thank you. On the note where my sister said, I'm not new in this region. I was Miss West Nile, where Acholi region was part. So at that time, I was the best, beautiful, looking lady to represent the whole West Nile region, Acholi region, now Acholi sub-region. But I'm going to hand over this matter to my sister. You can see her beauty is also matching towards my beauty. So, my sister, at an appropriate time, I think we shall have a function in the all northern region. I hand over to you officially. Having said that, I'm therefore delighted and honored to welcome you all to this annual Regional Health Assembly in Acholi sub-region. As I have said, the ministry takes keen interest in today's occasion, one of the many occasions, or the few occasions that has gathered different stakeholders together to look at the situation within the northern region. This assembly is therefore very timely amidst this COVID-19 pandemic because it presents us with an opportunity to share experiences, lessons learned and challenges and opportunities, and tested solutions in the implementation of health care and service delivery in Acholi sub-region. It also serves as a platform for peer learning about key services indicators among health workers and other stakeholders. Most importantly, it is an opportunity for all key stakeholders to share challenges, experiences, and propose solutions which are context-based. We are from the sub-region, and I'm sure from wherever each of you have come from, you have a different testimony. You have different case studies that we can share, and then we come out with the best solutions. To the planners in the sub-region, these are our technical staff and implementers. This assembly is an avenue for us to mobilize support, resources, and attention from the leaders present here and those online, and financing actors towards health care and service delivery in the Acholi sub-region. It's this time, and I want to thank the COW. As I came in, he addressed this issue of financing, inadequate budget, and the areas he thinks that will improve our health service delivery. The theme of this assembly, improving key health services indicators for the host refugee communities in Acholi sub-region through sharing knowledge on evidence-based strategies to effectively and equitably optimize outcomes. This theme was well thought through because it resonates well with the recovery process from long war which the sub-region went through, and also being a host over 50,000 refugees from Southern Sudan and the Iraq. On behalf of the government, on our own behalf as a ministry, we want to thank you all the citizens here, the leaders, every person for the good hospitality to ensure that you accommodate these refugees. Thank you so much. It is also a time when many health workers are being infected with COVID-19 in line of duty, and a number of them losing their lives to this pandemic. We salute these brave health workers as a ministry, and I would like all of us here to observe a moment of silence to our departed workers in the Ministry of Health and all the departed people who due to COVID-19. Can we stand up and recognize 1 minute of silence? May their souls rest in eternal peace. I take this opportunity to call upon all persons in the eligible categories for COVID-19 vaccination to take it very seriously and get vaccinated. Government has procured and continues to procure more doses of vaccines to protect the citizens. Each one of us here, I'm sure, has a case related to one of our relatives, our friends, anyone in our communities that has been a victim of COVID-19. It's very disheartening that as we continue from wave 1, we went to second wave, and this region also is not yet safe. Mark my words, not yet safe from the third wave. When I passed in town, I noticed that our people, the communities in Iguru town, out of 100, I think I would see one person wearing a mask. I took time off to drive slowly. You saw what I was doing here. It's not a matter because I'm the Minister of Health. Care for your life. Care for others, people's lives. Care for the community. Let's save our lives. Let's save others. Let's save every Ugandan. Saving starts with you. Then you move to your next. Then you go further. COVID is for real. We don't need now to say it anymore. At times I've been telling people that I get disappointed when you go and purchase a mask. Then you find somebody walking in town wearing it as a necklace. So in the first time, when you went to buy it, what was into your mind? Because you failed to get a necklace? Now, if you are not going for a necklace and you knew you wanted a mask, so there is a purpose why a mask should be worn. I sincerely call upon you in this region to take it upon yourselves to ensure we join hands, we create awareness, we mobilize our people. Now vaccines are available. Let everyone be vaccinated. We are starting with the students, the teachers, the non-teachers, the elderly. Vaccines are now available. I'm hearing a lot of things that maybe you too, you have heard. .com. Vaccines are not good for us. Me and my sister Grace who are yet to have more babies. If we take a vaccine, we shall stop at those ones we had. Yes, we have had 10. Grace, that is enough. If we don't add, God, let God be. Go and get vaccinated. The young girls have not have babies that won't have babies. Which scientific confirmation is there? Now the competition is, even you find, with due respect, the DJs, they are an expert on knowing which is the good vaccine. Their line is to ensure they give us and produce good music. But they are the ones telling us AstraZeneca is not good. A DJ, it cannot be good unless you have tested it. So how did you prove that is not good? Now we have had Moderna, that one is better. In which research laboratory did you get the results? This one is better than the other ones. Now you go and get herbs. You have not gone to find out the effects of herbs. So as a ministry and the government, we are saying, don't compete with researchers. if the researchers researched and found out that we need to be vaccinated, and vaccination is another way for prevention, and you are aware from when we are growing in our different mother tongues, they would tell us prevention is better than cure. That is why they would feed us on those herbals. Now we are in an era of .com. The herbals you are taking, yes, those are also part of prevention. But there is the best way to prevent yourselves against COVID. And in this manner time, it is to get vaccinated. You find those who have been vaccinated are celebrating. Me, I'm vaccinated. You who is not vaccinated, you are going to die. Unless you tell that person to get vaccinated, you will not miss dying. You will die slowly. But you would have been prevented that the effects once you get into contact with COVID, managing it would be more easier than the other one who was not vaccinated. Then those ones who are not vaccinated are happily drinking. We are waiting for those who are vaccinated to die. Imagine, those who are vaccinated have prevented themselves. Those who are not vaccinated are saying, I'm waiting for you to die. You find it in a family. I am waiting for my brother to die. He got vaccinated. He went for a second jab. I'm waiting to die. And you? Then the other one is saying, so this competition is not healthy. They need awareness. Go out there and tell them there's no competition in this COVID vaccination. The only alternative is everybody in the home, everyone that has said, get vaccinated. Once we have, the minister has said that when you have a healthy community, you have healthy acceleration of development in the region. If you have a sick community, the whole development, the whole community will be sick. There will be would be no results show because everybody is sick. A sick mind, a sick body, there is no result. So if we are here looking for results, and the purpose why we are here, let's start to say we need to have a healthy community within the Acholi sub-region. So discuss how you are going to achieve that. For us as government and Minister of Health and my sister, we have to do the policy, guiding, direction, supervision to how to achieve a healthy community in Acholi sub-region. If the communities are very sick, even sick in mind, development stagnates. And we are here talking about development. Health service delivery is all focused to ensure that the communities are developed. We are talking about household income. We started with all those programs. We went to Ntandikwa. Everybody get rich. We are now at the parish model. Now, when they tell you, let's mobilize our people for parish model, please, that is another way to ensure we get out of a sick community, at least our households. So I ask you and I appeal to you that one of the reasons you are all here is to find ways and means to move out from a sick community to a healthy community by ensuring not only health service delivery, but very good quality service delivery. You may give service, but if it is not, there's no quality into that. So I'm sure that all of us here, it is also a time when many health workers, as I have said, you must get out there. Why would you have your health, our health, who have not been vaccinated, and they are the first contact with these communities? their lives are in danger. They are spot on to get affected. And here we are saying, we are mourning, we are grieving. You can't go to teach somebody to read the Bible when you have not read the Bible. You are teaching me, a Muslim, to look at what Jesus did and wherever, and bread turned into whatever, and water into wine, and I'm a Muslim. You first read that one, internalize it, go out and preach out. Jesus started preaching to the disciples. That is why we are here to preach to you. When you leave here, go and preach also to others. Not necessarily that I'm a good preacher, but when we join hands, our message can be heard. So our health workers, we plead with you, and this is the reason we are here. So we need in your deliberations and resolutions to give us as a ministry how you are tackling the issue to ensure that all our health workers and our teachers, those who get in touch, the first focal people, our VHTs, don't have a VHT in the communities who is not vaccinated, because they are the ones who are now at the village levels. Ensure that every VHT person is vaccinated. Vaccines are here. Ensure all our health workers at all levels. Ensure all those who are dealing with the maternity and what have you in the homes, they are vaccinated. That is when you are going to have a very, very vibrant community that is free of disease. I take this opportunity, therefore, to call upon all persons once again to ensure they are vaccinated. Vaccination is taking place at different areas in different sub-counties, and I'm sure the DHO, COW, and the residents, these commissioners, now you are aware, and the National Task Force. I heard the COW saying that the National Task Force needs to be strengthened. It is true. And as the ministry, I am happy that we have our technical people here from the ministry. Maybe they could stand up, just stand up to know that we took this keen interest in this assembly. Keen interest. Our directors, our commissioners, you can see how the ministry takes issues of health with keen interest. I thank you so much. From here, we are going to Lira. So I want to say that it's upon us, because the way you are selected by a purpose. And within your area of execution of your work, and knowing you are going to supplement on the government's effort, Ministry of Health effort, and to supplement on my sister's efforts to reach down to ensure the cause of this assembly will live with us, that there was some result oriented. I would like to reiterate the ministry's resolve to engage all the relevant different stakeholders to ensure that sharing knowledge on evidence-based strategies is effectively and equitably optimized for better outcomes as we move towards universal health coverage. Our mission as a ministry and a government is focused to moving towards universal health coverage. I would like to urge all participants in this assembly to also use this opportunity to highlight the key bottlenecks and challenges that you encounter in your endeavors in the health care industry. At the same time, we should also try to find and discuss solutions to some of these challenges, which solutions definitely the Ministry of Health would be happy to take keen interest to address them. Whereas the country has done a great job in bringing service nearer to the people, the quality of the service we are offering is still low. This is another challenge that you need to look at. How do we improve on the health service that currently we are offering? This therefore tells us that we should shift to the focus on sharing knowledge on evidence-based strategies to offer the quality service. On another note, I would like to sincerely recognize and appreciate, as my senior minister had done, the United States of America through its agency USAID, and we want to thank our acting director, and I want to thank him for his presentation and the support that he's giving us as a government and the Ministry of Health and other agencies, government agencies. Thank you so much, USAID. We want to thank United Nations and her agencies, UNHCR, UNFPA, UNICEF, that for a long time have been here with us in the northern region, the World Health Organization, and Belgium Development Agencies. We want to thank you so much for your support, and we look forward to further cooperation as we have been doing to ensure that there is improvement in the healthcare service in our country. Thank you so much. We thank your citizens in your country, because whatever donation, whatever you are giving us as a country, we know it comes out from the citizens in your country. We want to thank them. And we want to thank you for the good cooperation between your countries and our country, Uganda. Allow me, ladies and gentlemen, once again to recognize other partners in the service delivery in Acholi sub-region. You see, once you don't say thank you to somebody, that somebody would feel that you are not appreciative. Universal Research Company, you are assist through various USAID supported projects, as has been elaborated. United Nations Population Fund, USAID, SBR, and WVI. Guru University, the COVID-19 testing laboratory. We are looking forward for this laboratory. It needs support. You discuss how you can support it. For the ministry, we are doing, and the government, our best. But it needs local support. You need to own it. It is good for us all. And the USAID, Uganda System Strengthening Activities, UHSS, we thank you so much. Take our thanks as endless. Thanks for endless support you are giving us as a ministry and the government. Ladies and gentlemen, I'm pleased to note that the Acholi sub-region has been able to organize this annual regional health assembly amid this COVID. I want to call upon you. I am happy that you are observing the SOPs. But once you get out of this hall, please continue the same. Let it not end here. When you go to the dining, when you are walking out, maintain it as you have displayed. Thank you so much. I'm informed that there are about 150 delegates. Because of the SOPs, they couldn't be here present. But happily, they are with us online. I want to thank you all, and I want to encourage you that you participate fully with the participants who are present here. Before I conclude, I wish to recognize and appreciate the keynote speakers, my senior sister, Minister of Northern Region, our acting director, you said, the COW, our deputy mayor, and everybody. I understand that this assembly is going to take 2 days, and I'm very hopeful when I look at your faces. You are very keen and saying, why doesn't this minister stop here and we embark on real action? I'm one person who enjoys action-oriented results. But I'm talking to you so that you may know that I'm what I am because I originated from you. When I was Miss West Nile, I was one part of the health workers. I was in Arua, and I enjoyed putting on that pink uniform. But when the pink was so beautiful, and it combined with the beauty of the person, I went for the beauty contest. The rest is history. Then I'm happy that you can't decide your destiny. The destiny came back and they say, go back to where you ran from. I'm back in the Ministry of Health to embark on the job that I ran from. So when I'm here, I am part of you, reason that I take some time. So as I conclude, I would like to appeal to all of you to use the knowledge shared from this assembly to improve the quality of health services to all Ugandans at all levels. This is part of our mandate as a ministry as we contribute to the human capital development as clearly outlined in the National Development Plan 3. It is only a healthy population, I repeat, that can engage in income generating activities that will improve the economy of our country as we aspire for and move towards the middle income status. Ladies and gentlemen, once again, I want to thank our development partners who have joined hands in sponsoring this important assembly, the organizers. If there were no organizers, of course, there would be nothing. And then I want to thank you, the participants. They made fund, an assembly, a function. The organizers, if they are not there to ensure their work is to organize to its conclusive success, and the participants say, we are not going to attend and listen and share. So all of you partners here, our family friends in the Ministry of Health, we want to thank you so much, and we want to wish you fruitful deliberations and productive a 2 days assembly. As I have said, the ministry has taken keynote of what so far has come out, but at the end of this assembly, the ministry will not be the same. The region, sub-region will not be the same. We would be moving towards a focused working paper that focuses on improvement of service delivery, not only in the health sector. It will touch on economy, it will touch on all development, because once we have a health community in this region, we'll have development that accelerates our economy. I thank you so much for God and my country. Thank you.
Well, thank you very much, ladies and gentlemen. A very big round of applause for our opening. Thank you very much. I also like to say thank you to the session chair. Madam, thank you for doing your work very, very ably. Ladies and gentlemen, the RDC for Agago, Susan Akan, thank you for that. Thank you very much for that activity. Just a few housekeeping things, not housekeeping as such, but just notification. I'm told by the press team that there will be some press briefing, so they will identify some persons to come and say some few words. I know the director, referral hospital will be part of it, the ministers will be part of it, so it will be arranged for you at that spot. So when they call upon you, please make yourselves available for that. I'm also informed that since the room is getting a little bit full to capacity, the other second room, the ballroom hall, is also available, and it has a live feed in there as well. So if you can take time off and you take yourself that side, you'll still receive the live feed that is in this room as well. Then another word of caution to the session chairs. Presentations are 15 minutes strictly. You can see the time we're on right now. It's past 11, okay? Presentations are 15 minutes only, and then thereafter you have about 30 minutes or so for discussions with your team in your different capacities. So please maintain that time so that we don't overstretch, because when one side is not complete and the other is completed, then we shall have a lot of movements which will disrupt our progress. So let us keep that at that stage. Now, like they said, let the work begin. I would like to invite the next session chair for the keynote speaker. And I want to invite Dr. Janet Oola, the DHO of Noya, to come and introduce our keynote speaker for today, Dr. Sarah Biachika. Dr. Sarah is online. Dr. Sarah is online, so the session chair will introduce her. And immediately after her presentation, which is about 15 minutes or so, we shall go in for a group photo. I'm also informed that the group photo will be done in here, in the hall here, and also breakfast will be laid out for us here at this point. So after your breakfast, please break out into your room straight away. And we need those session chairs as per the program to wait for the participants in the different rooms. Elephant Hall is here, Ballroom Hall is the next one on the other side, okay? So we shall have about 45 minutes only for breakfast. So we shall get out, have breakfast, get photos, breakfast, and we break out straight away. Session chair, Dr. Janet, please introduce the keynote speaker, and she will be connected online, and she's waiting. She's with us.
Good morning, everybody. I hope you've enjoyed Gulu District, our mother district. Dr. Janet Ola, I'm the head of DHOs in this region and the DHO of Noya District. You're all most welcome to the region. I have the privilege to chair this session, and I'd like to introduce the keynote speaker, who is Dr. Sarah Biachika-Cheyamwa, a public health specialist and health services manager with vast experience of working in the public health sector from district to national level. She's currently the Commissioner Planning, Finance and Policy, and is the National Results-Based Financing Coordinator and focal person for the establishment of the National Health Insurance Scheme in Uganda. Dr. Sarah Biachika-Cheyamwa has taken lead in development of various health policies and strategic plans, including the National Quality Improvement Framework and strategic plans, national M&E plans, the health financing strategy, the first national COVID-19 preparedness and response plan, and the third national health policy 2020 to 2030 that is awaiting final approval. I'd like also to declare that she was my classmate, and I'm proud to introduce her to this great meeting. Thank you. I hand over to her, Dr. Sarah Biachika.
Yes, thank you, Janet, for that introduction. And good morning to you all delegates to this first review mission, pre-joint review mission. I really would like to apologize that I got mixed up, and as I was setting off to Gulu this morning, I was told that no, the meeting is today. So I'll make my presentation from my office before I set off for other activities in that region. So good morning, and I'm sure you have my presentation already. I'll start straight away because I have limited time to catch up on the program agenda. So I'll provide an overview of the health sector performance for the last financial year. We can move fast because there are quite a number of slides. I'll quickly go through them. So please proceed with the slides. And as you are all aware, we are now implementing, this is the first year of implementation of our NDP3. And there are key result areas for the health sector. Next slide, please. Let's move the slides. The key, where did we start? So we have the vision, mission, and human capital development goal for the health sector, which is improving productivity of labor for increased competitiveness and better quality of life. Next. As a health sector, we are aligned to these key outcomes under the NDP3. Number one is increasing life expectancy, reducing neonatal, infant, and under 5 mortality, and then reduced fertility rate. So those are the key results, outcomes. And then we have 6 key result areas for the health sector. And my presentation is to share progress in the first year of the NDP implementation as far as these key results areas are concerned. Next slide. Under improving skills mix, our target was to have at least 20 health workers, critical health workers, that is doctors, midwives, and nurses per 10,000 population. We achieved only 19. Our target was not achieved, as we are aware, due to the COVID constraints. A number of graduates were expected to qualify from the training schools did not qualify. However, due to improved registration of doctors by introduction of e-registration, we achieved beyond the target and have 1.7 physicians registered per 10,000. Overall, total approved posts is 74%. We didn't achieve the target. And as you can see by level, The regional referral hospitals are the least staffed with 69%. Next. This map shows us the staffing levels, and as you can see already, the region where we are reviewing, Amuro, Guru, Omoro, I can see our staffing levels are green, which shows that they are above the national average. It is only Padel, Lamu, Kit, and Agago, I think, where the staffing levels are below 55%, and we need to do something about that. A deeper analysis shows that in terms of the leadership at municipal and district local government, at municipal level, the most field positions are the principal health inspectors, and at the districts, it's the biostatisticians. Whereas in terms of principal medical officers, the municipalities are really performing very poorly. And also in terms of staffing, health educators and assistant district health officers, we see that these positions are not well staffed. Can we skip that slide because of time? We'd also like to say that we would recognize the performance of our health workers. For example, last year, we had our health professionals from Soroti Regional Referral Hospitals being recognized by Parliament for successfully separating one twin from the other dead twin. So these were conjoined twins, and one was dead, but they were successfully, the operation went on successfully. So this is just to appreciate our health workers. Amidst all the challenges, there's a lot that is being done, there's a lot of commitment, and this is appreciated. Next. The second key result area is reducing morbidity and mortality. And here, the area of HIV infections new HIV infections per 1,000 susceptible population, we had registered more infections and not achieving the target. 95% of the HIV positive mothers were initiated on ARVs, surpassing our target, but we did not do well as far as PCR, fast PCR for the exposed infants, where we achieved only 77%. ART coverage also were not much, as there was some improvement. We did not achieve the target for the year. And although we achieved that for ARV virus suppression, the COVID-19 effect on, as we know, had effect on some service delivery, including HIV care, especially ART, because of access, but also we know that there was a shortage of some of the ARVs. So in terms of regional performance or district performance, we can see that the region under review is performing, some districts are performing well, scoring over 75%, whereas Gulu, Padel, there's need to improve, including Omoro. You can see your light color. We also assessed percentage of women tested for HIV in the current pregnancy, and we can see that our region under review today, most of the districts are under yellow, that is between 76 to 86%, with Ramu having over 75%. So they still need to improve in terms of HIV services. Overall ARV availability was only 79%, a drop from the previous financial year, and this obviously affected the service provision. Next. In terms of TB program, we achieved our target of 192 per 100,000 population TB instance. And then notification, there was some improvement, though we did not achieve the 172%, we are 161 per 100,000. Leprosy is still a problem in Uganda. And here the indicator was looking at leprosy patients presenting to health facilities with grade 2 disability at the time of diagnosis, we actually had 50% of the patients reporting with grade 2 leprosy against the 13.8% target. And this is largely due to the low awareness of leprosy, delayed diagnosis, and so there is need to increase awareness about this disease. TB case notification in the region under review, we can see there's fairly good performance with the exception of so build capacity for the health facilities to undertake this. Next slide. We can move to the next. Sorry, that slide should not have been there. Next slide. Children under 1 year fully immunized is to be determined by the demographic health survey. However, for DPT and measles coverage, we did not achieve our targets, largely due to reduced access to services and also the resultant fear of people going to health facilities and also reduced outreaches due to COVID-19. So those indicators, we actually have seen a negative trend against the positive trends that we had been realizing earlier. Next. I've already talked about the zoonotic diseases being managed or disease outbreaks. Another positive achievement was the elimination of blinding trachoma, where we achieved a target, 90% of the targeted districts were able to eliminate. We are mainly remaining with trachoma in districts of Moroto, Amdat, Nablatuk, Nakarpirprit, and Bulisa. And that is where now the interventions are focused. In terms of COVID-19, only 1.2% of the population was vaccinated, as you are all aware, due to the low availability of vaccines. However, in the area of COVID-19, disease surveillance has been strengthened at all levels. We had all points of entry activated, and also in collaboration with partners, we developed standards, guidelines, and enhanced the surveillance and contact tracing. We have made several investments, especially at the POEs, including orientation of border health communities, installation of thermal scanners, and also providing IT equipment and internet connection to improve on surveillance. Next slide. I would also like to mention that during the year, Uganda was ranked by the medical journal, The Lancet, as one of the top 10 best performing countries in suppressing COVID-19. That was as of August 2020. And this ranking made Uganda the best performing country on the African continent. And this is a position we must all be proud of. And largely, we would like to thank the frontline health workers who have committed to serving Ugandan citizens afflicted by the COVID-19. I think as a country, we are very proud of that, and we hope to sustain that. Next slide. In terms of NCDs, high blood pressure, the National Household Survey 2019-20 showed that there's been an increase in the population with high blood pressure, but worth noting is that the female are more affected. The high blood pressure incidence or rate in males is 2.1%, whereas for females is 4.8%. And so we need to have action towards that. As far as diabetic rate is concerned, the survey showed a drop from 2.5% previously to 0.8, and without much difference between male and female, though females have 0.9%. This map shows that Acholi region where we are now is among those with the lowest, as far as diabetes, they have the lowest proportion of the population with diabetes, as well as blood pressure. So we need to sustain whatever behaviors that are leading to this so that other districts or regions in the country can also follow suit. IPT3 coverage is an indicator that has been performing very poorly over the years, but would like to appreciate that it has increased to 59%, surpassing our target. Anemia screening is still very low. When we actually had a negative trend, having 21% versus the target of 50. We achieved our target for ANC4 coverage with 50% against 46%. IPT and ANC4 coverage are one of the RBF incentivized indicators, and that could be one of the reasons why we have that marked improvement. Amuru, Guru, Omoro are performing fairly well, including Kitugum, as you can see there in yellow. Lamo, Agago, and Padel are average and need to improve as far as IPT3 coverage is concerned. Next. Facility deliveries, we achieved 64 against 65% target. And then we have seen a negative trend as far as health center post providing SEMNOC services is concerned, achieving 44% against the 56%. And this is an indicator that is really needs to be supported and followed up so that we can reduce on maternal and neonatal mortality. Out of the 207 health center posts, 162 carry out cesarean sections. However, 70 of them do not have blood transfusion services. And we know one of the major causes of maternal mortality is hemorrhage. So doing a cesarean section without blood transfusion is very risky, and so we need to improve on that area. Maternal death mortality, health facility-based maternal mortality, we did not make any progress. We remained at 92%. There was improvement in facility-based fresh stillbirths, whereby we surpassed even the target. And maternal death reviews improved, though we did not achieve our target of 76%. There was marked improvement in perinatal death reviews from 9.7 to 41%, surpassing our target, largely due to the functionalization of the MPDSR committees, where the reproductive health department holds weekly meetings with the ADHOs and following up on this. So we need to sustain that. And still the mapping shows that Amuru and Lamu are performing very poorly as far as and Omoro as far as maternal death reviews are concerned. But surprisingly, Lamu and Omoro are doing fairly well as far as perinatal death reviews. So we need to handle both concurrently. We are not able to assess the teenage pregnancy rate, and young people are accessing age-appropriate information due to lack of data source. And then mortality attributed to injuries reduced largely, as explained, due to the lockdown effects. That was the longest key result area. Now we go to improvement in social determinants for health. The Uganda National Panel Survey of 2019 showed a reduction in stunting, largely to 25%. However, we see that stunting rate is still high among the male children at 30.8%. Wasting also reduced dramatically from 14% of the population since the last demographic health survey of 2016. The panel surveys shows that wasting now is at 3.2%, although there is higher wasting in the urban areas compared to the rural. Next slide. Vitamin A second dose, also we achieved our target, achieving 48% coverage. Sanitation, access to basic sanitation, specifically improved toilet, not shared with other households, is at 24.5%, achieving the target. And population with hand washing facilities also increased to 44%, surpassing the target of 34%. Tobacco non-smoking rate, we are doing well, fairly well as a country, and have progressed from 90% to 97% of the population as non-smoking, with Karamoja having the highest smoking rate at 16%. Total fertility rate is yet to be assessed. However, World Health Statistics showed that adolescent fertility rate was at 111 per thousand. We don't, this was in 2020 report, but we know that due to COVID, the story is quite different. Next slide. We are not yet able to assess the new acceptors of all users of modern contraception because of our data is not yet accurate, but couple years of protection increased by almost close to 2 million, over 2 million to 5 million, 277,687. We expect that this could have an effect on the total fertility rate. We have a key result area on universal health coverage, where we saw a drop in general government allocation for health as a percentage of the total government budget, largely due to the reduction in overall national envelope and exit of some projects. However, in addition to this, we received some supplementaries, largely for COVID-19 response. So the funding is not yet where we expect to be. Out-of-pocket expenditure is still very high, with 41% of the total health expenditure being out of pocket. We had expected to reduce this, but the National Health Insurance Scheme is not yet in place, so we still have experienced that. Government per capita expenditure on health was 18%, which is still also far below the target. And readiness of capacities to provide general health services was only 58% out of the target of 60, based on an assessment carried out in 39 districts. So I'm coming to the end, Chair, of the presentation. We can skip that slide and summarize that. Next slide. Overall performance in terms of essential medicines, there was reduction in availability to 78%, and I'm sure the districts can attest to this. Next. Next slide. Next slide. Next, we can skip. Yes, we know that management of medicines is very critical. So supervision, performance assessment, and recognition is one of the tools that has been adapted by the pharmacy department. And we see that our districts under review are performing averagely in terms of medicines management. So there's need to improve on that. And the overall in the country, the best health facility in terms of medicines management was actually from Koboko. It's called Dranya, which scored 24.9% out of 25% score. So the health center 3 seem to be performing much better than other facilities, though some of the health center 3s in terms of medicines management. The National Household Survey showed an improvement in access to health facilities from 86% to 91% of the population now living within less than 5-kilometer health facility radius. Next. And this is largely to investments that have been put in upgrading health center 2s to health center 3s. I'm sure some of these are familiar in your region. Next, such new structures that are coming up. Next. We had a number of referral of general hospitals renovated. For example, Kayunga, that is the new face of Kayunga. Next, and Yumbe. Next slide. And these have been upgraded to regional referral hospitals. So that is what we are aspiring our hospitals to look like when resources are available. Next slide. We have a new children's surgical hospital that has been established using the public-private partnerships. This hospital is based in Entebbe, and I would like to inform members that it provides free pediatric surgical services in Uganda and the East African region. So if you have any children that need pediatric surgery, the issue is to have them reach Entebbe and they'll receive free pediatric surgical services. We had planned to have all our referral hospitals with CT scans installed, but we were not able to achieve this. Currently, we still have only 2 hospitals, public hospitals in the country with CT scans. However, funds have been provided in the current financial year to procure CT scans for all our 14 regional referral hospitals. So we expect that next year we'll be able to achieve this indicator. In terms of functionality of X-rays, we are only at 57% of hospitals with functional X-rays. And we have to recognize that we received some new X-rays for Kabong, Bududa, Kamuli, Katakwi hospitals, and Breakable Health Center in Isingiro. And of recent, 2 X-rays were donated to Maracha and Arua Regional Referral Hospitals by the German government, sorry. We have had improvements in infrastructure as a result of COVID in terms of ICUs for all our regional referral hospitals. However, the challenge is in utilization of this equipment due to lack of space and specialists to operate them. We have received 116 ambulances as a result of the COVID-19 response, and we are expecting to have 14 new boat ambulances also deployed on the large waters in the current financial year. The ambulances are to be managed under the regional ambulance coordination mechanisms. We have also strengthened our oxygen infrastructure in some of the hospitals, and plans are underway to enhance the capacity of all the regional referral hospitals through procurement of additional oxygen plants, as well as liquid oxygen plants that will be installed in the regions. In terms of data management, we are in the process of rolling out electronic medical record system. And so far we achieved only 16.4% of the hospitals and health center falls with electronic medical record system. This is work which is ongoing, but that we shall report as we progress. Next slide. Next slide. Chair, in the area of data management, we still have to address the issue of quality of data. We're not able to assess the error to data ratio. Our target was to reduce this by 58%, but we are yet to undertake the DHOA. Next slide. Yes, we are emphasizing the aspect of community, shifting from facility-based healthcare to community health programs. And here we monitored the completeness of VHT quarterly reports, where we are at only about 45%. And yes, we need to strengthen this area as we are looking at a strategic shift from facility-based to community health programs. The region under review is performing to a large extent fairly well as far as the VHT ICCM quarterly reporting is concerned. Chitugum, Agago, though, need to improve, as well as Omoro. Next slide. As I summarize, Chair, out of the 29 key result area indicators, we are able to achieve 10 targets for 10, that is 34%, and progress made in 17%. 17% we did not achieve our targets, and were unable to assess 31% of the performance indicators. So overall, that is the summary of the sector against the key results indicators, and would like to acknowledge all the people listed here who have contributed to this, but more especially the grassroots health workers who have sustained our response to the population health needs amidst the COVID-19 challenges. Thank you, Chair, for listening.
Thank you so much, Sarah. Let's clap for her. That was wonderful. Of this session. Let's welcome Honorable Minister of State for Health in charge of general duties, Honorable Anifa Kawoya Bangirana. You are most welcome.
Thank you so much, moderator. And I want to thank our last presenter, Dr. Sarah Biachika, which brings us to this important occasion of declaring our assembly open. On those remarks that she has outlined on the key areas and the performance indicators where as a country, as the Ministry of Health, we have done our best, and where some areas definitely need some improvement. And this is a food for thought for the participants, that at least she has pointed out areas of keen interest where all of you, the participants, you must take keen interest and come in where the indicators are of performance are good, you take note of that. But where the performances are still wanting, again, you have to share out and see the way forward. I therefore take this opportunity to declare this assembly open. Thank you so much.
Thank you, thank you, thank you. We've now come to the end of this session, and I hand over to the organizers. Thank you.
Thank you very much, ladies and gentlemen. Thank you, our guest of honor. Thank you for those words. Ladies and gentlemen, our meeting is open, okay? And just a bit of housekeeping, like I said, we are going into our break room sessions. But before that is our group photo, and this is how I'll guide. Madam Guest, please, we need to take some pictures with you before you leave. So just come in front there, and I will also call on the other persons to be present amongst them. It's a group photo. The representative of the DHOs, the representative of the RDCs, the leaders of the representative of the LC5s of the region. We also need a representative of the COW, the Chief Administrative Officers. We also need a representative from the implementing partners here. I know we have leaders of these teams I'm talking about. The DHO leader here for the region, the leader for the RDCs of the region, the leader for the LC5 in the region. I'm also calling upon our colleagues from the Ministry of Health, the directors and the commissioners. Please join the team. Let us line up very quickly. And we have our photo very, very quickly. The Director, Gulu Regional Referral Hospital, please stand up and join the team. We have representations from our partners. Please, the different partners, implementing partners that we have here, please come and join the team. The Mayor, Gulu City is here. Please join the team. Directors and commissioners from the ministry. And I'm also informed to let you know that the media houses we have present right now, we have Radio Rupin, we have New Vision, we have Mega FM, Daily Monitor is here, NBS is here, NTV is here, URN is here, Urban TV is here with us. So please let us take that. And immediately after the group session, we are going for breakfast. It's a very big circle, I can see. Can we align ourselves in such a way that the semicircle is not too wide? Or we get some chairs for, yes? Our ministers, please, you can take a seat, probably. Can you have our ministers take their seat? Dr. Kware, please, Director, please take a seat. Can the mayor and the RDC for Gulu City take this? And ask, can we now join around them, please? Our photographers, please snap away as they arrange themselves. Keep snapping away. I was going to say cheese, but I cannot see it. Yes. Is that it? Can the photographers extend a bit behind? Yes, that's what it is. We also have persons of official photography, okay? Yes. Don't forget that you're live. The other participants are watching you. We shall take their photos individually, or they'll send it to us on WhatsApp. As you take the photos, the following persons: our Honorable Guest, Chief Guest, and the Minister for Northern Uganda, the Chair of the Board of Gulu Regional Referral Hospital, the Director of the Gulu Regional Referral Hospital, the Chair of the DHOs in Acholi Sub-Region, and the Chair of the LC5 in the region, that's the Chair of the LC5 of Kitgum. You're required for the press briefing here on my left. Madam Ministers, you're required for the press briefing just on my left. The Board Chair for Referral Hospital, the Director, Gulu Referral Hospital as well, the Chair of the DHOs, that's Dr. Janet, you're also required on this side, and the Kitgum LC5 chair, you're required on this side. Ladies and gentlemen, the rest of us, let's go for breakfast. And like I said, time is now coming to midday. Thank you, DJ. Ladies and gentlemen, our break room. Yes, these are our breakout sessions, ladies and gentlemen. Our session has started. Like I said, one session is in this hall, Elephant Hall, and here we shall have the chairperson LC5 of Gulu as the session chair. And the ballroom hall is next door, where we have Ms. Margaret Katusime from Enabel as the chairperson there, as the session chair at that point. I am advising that as a session chair, the time allotted for the presenters is only 15 minutes. And for this session, we have 2 presenters. After they have both presented, then you invite discussions for about 30 minutes. It's a midday now. 15 minutes times 2:30, about 1:45, and probably by another 1:15, we should be winding that session up so that we go for lunch break. So, Chairman, please, you will take your seat up. Our session chair, like I said, for this hall is the chairperson LC5 of Gulu District, Mr. Pio Christopher Teke. Please. And Margaret Hall, I know you're listening to me. Your session chair is also there, Margaret Katusime. Not Margaret Hall, sorry, Ballroom Hall. Your chairperson is Ms. Margaret Katusime there. So can we call upon the presenters for the different sessions to avail themselves? The session chair will present you and you make your presentation. For example, for this hall, the Commissioner's Cap from the Ministry of Health, Dr. Sendioma will be here, and Dr. Rabin Drabe from UNICEF is also here. And for the ballroom hall, we have Dr. Patrick Okello, Commissioner of Human Resource, and Dr. Charles Oyo Akia, NCD, Commissioner NCD is also there. Like I said, let us keep movements to a minimum because the virtual team is also attending with us. Let us not forget that we have another team who are attending virtually as well. So let us keep our movements or reduce on the noise that we have. Chairman, you can take over.
Good afternoon, ladies and gentlemen. My name's Opio Christopher Ateker, LC5 Gulu District Local Government. Allow me to welcome you back from our breakfast and also to thank the organizers for actually organizing this very important annual health assessment assembly for Acholi sub-region. I know it is not easy, and this is the first assembly of its kind. I know you are encountering a lot of challenges. Even though you're encountering a lot of challenges, I'm sure that you will also learn a lot from this first assembly. And next time we'll be having this kind of workshop. It will help us to improve more. However, as the chair of this session, I want to highlight some of these key issues that the presenters are going to take 15 minutes each, and thereafter we'll take 30 minutes for discussion. Then thereafter, by around 1:15, we'll be winding up. So with these few remarks, may I invite the first presenter of this session, that is Dr. Martin Sendiona. Oh, that's right, he's the one coming. Doctor, take the podium, and you've been allotted only 15 minutes. So use your time appropriately. You're welcome. Something missing? Oh, yes.
Hello, hope you can hear what I'm saying. Thank you very much, Chair. My name is on the screen, and I'm here to talk about regionalization of health services. You can see Acholi region, but I think you are looking at the whole country in general terms. And we need to see how this can be done. And I'm very happy to be here and appreciate the organizers for this function, for the job well done, and also to add that we hope the beginning of a story to continue for many, many, many years to come. I work in the Ministry of Health. I'm in charge of the department responsible for quality of care. That is the name, standards, compliance, accreditation, and patient protection. Next slide, in the interest of time. Yeah, I'll talk about the background, justification for this. I'm sure I'm talking to the converted, so the story will be easier to tell. Then implementation process, structural arrangements, roles and responsibilities, the funding, and the monitoring and evaluation next. That's our population, and the number of districts is growing. We all know that. We are at 135, and I'm sure I suspect the number may increase. And have urban authorities. The number I have is 22. It could be more than that. And of course, have the ministry as an institution responsible for health services, the regional referral hospitals, and the local government and authorities in place. We all work together to provide service to the community and the public. We have the regulation in place for all this we are doing. There's a constitution which gives us the overall governing authority. We are supposed to provide access to services, clean and safe water, environment, and education, all those basic social services. It is a constitutional obligation. The Public Health Act also in place, whose main objective is really to ensure protection of the public health and the community. In Uganda, we have a local government act, and we have the mandate. All these are the legal framework within which we operate. The Ministry of Health has the responsibility to form policies and guidelines to do the overall coordination of activities, health-related activities in the country, and engaging the stakeholders at national, subnational, and the community level for health service delivery. Next. Next. So, as the ministry, I think as an institution for government, it has a responsibility of oversight role over all the regional referral hospitals and of course the local government authorities and entities and health serving units. The regional referral hospitals are the referral centers for the districts where we are. Gulu is doing that as a function. Then of course the regional referral hospitals, as we know, they have the human resource capacity. They have the consultants, they are specialists, different service providers for the region. And of course, we are aware that the reviewing of this structure is underway for the local government and as well as for the districts, and we hope the situation is going to improve in the short and long run. And we definitely have the community health department, which is already playing a pivotal role in the provision of primary care services in the region. Next slide. Okay, all the regions up to now have been, all the regional referral hospitals have been assigned districts they are responsible for in the country. There are 16 of them, and each of them now has, you must be familiar with the districts which are responsible, which are in charge, which they form part of the catchment area and the region for the regional referral hospital, including the new ones. Even Yumbe, even Kayunga, and Entebbe, they have been assigned. The hospitals we have, the hospitals.
Excuse me, presenter.
Yes,
since you are far away from the participants, you can really remove your mask so that they get you clearly.
Good,
Please.
Thank you.
However.
You have made my life easy because it was falling off. Now, each of the 16 regional referral hospitals has a defined number of districts that they are responsible for, and this has been done for all the regional referral hospitals, including the new ones, as I mentioned, Kayunga, and Yumbe, and Entebbe. Formerly, we had the Nagulu being responsible for the districts in the center. Now Nagulu, Kawempe, and Kirudu, they are national referral hospitals. I'm sure many of you know this. Next. Next slide. So that is the list up to the 16th, and I am now, and the population is also defined so that this information is readily available, and we can share it for those who may need it. Next. The guiding principles for the regional support to the districts would be, number one, effective leadership, governance, and management. And I'm very happy when we've been here, we have seen this taking place, and the hospital director of the regional hospital has been taking lead for this, and I think it is one of the key principles we think that we need, we can take forward the regionalization process. Stakeholder participation, the key actors, we need to define them and know them and get them participate, all of them. The partners, the civil society organizations, the politicians mention it, all of them should be involved. We have the community health department in the regional faro hospitals. It's supposed to be to spearhead. It's supposed to spearhead this availability and coordination of the regional support. And therefore it has to be empowered so that it has a competent workforce and also facilitated with the human resource and other requirements to get this job done properly. We have to plan for sustainability, and more so the financing has to be taken care of, and we need to have effective communication because this is regional and you have the center, you have different actors, so it must have proper communication mechanism in place. Next slide. Then structure, which structure do we need? We need a steering committee. It has been the name proposed, the Regional Health Steering Committee. It should have a representation from regional referral hospital top management. The hospital director is supposed to chair this committee, and the secretariat to be headed by the head of the community health department. And then, of course, the DHOs in the region being members, urban authorities, including cities and municipalities, and the health development partners, and the Ministry of Health participating. This is the structure proposal being in place. Next. Next slide. So the tasks of this committee is to hold regular, quarterly, and annual review meetings like the one we have here, and also to have a work plan, review and approve a work plan for coordinating functions, and advise the programs in the region, approve guidelines and tools to be used, and also perform the role of recognition and reward for the performance. Next. Next slide. So the areas of support in the regional context we need to put into consideration. Support supervision and the mentorship. I think the hospital director of Gulu talked about this one. We have the Minister of Health Comprehensive Support Supervision Strategy. It should be implemented, and this is the opportunity we have. And we need to support the districts to improve quality of care. I think the hospital director mentioned everything when he was opening his opening remarks. So we need the technical support to the districts, especially general hospitals and health center to be functional. We need to address the issue of quality improvement. We have the regional capacity in place. Regional capacity has to be strengthened for 5S and quality improvement. We have the structures in place at the regional level. So this is, again, an opportunity for it to be improved and strengthened. We need capacity building for the regional referral hospitals in general. These are the referral centers, as I mentioned, for the region, for the district, for specialized care. This has to be improved and strengthened. The hospital director mentioned it about the specialists required and the human resource requirement. And of course, the logistical requirement has to be taken care of. The tools and the data management, use of data. The Dr. Sarah just shared with us data at the center, so we need it at the region to be properly addressed. Next.
Dr. Martin, you're remaining with the 3 minutes.
Fine, I'm going to summarize.
Yes, please.
So we need the other area of support is coordination of health programs. There are many, as you see on the screen, so we need to take care of that. And also to deal with integrated disease surveillance response. There are many challenges here expected, like accidents and the antibiotic resistance, among others, and the unexpected, like natural disasters and disease outbreaks. We need to plan for those ones. Next. Regional health research operations and the community health services as indicated on the screen. Next. Organizational arrangements, how this can be, the regional support be allowed to take place. We have the Ministry of Health, the actors are indicated on the screen, Regional Referral Hospital, the steering committee districts, the health facilities, General Hospital Health Center for the community, and the development partners. Next. That is the diagrammatic arrangement, as you can see on the screen. Next. So roles of the responsibilities of each are specified. The ministry provides the policies, resource mobilization, support supervision up to the regional referral hospitals, and strengthening the logistical requirements. Next. Regional referral hospital, the team, I've talked about it already, has to coordinate the supporting and support implementation of regional support. The districts has to be play the leading role, by do partner mapping, mobilize for resources for that purpose, and also also facilitate implementation of the different areas, including monitoring and evaluation. Next. The community health department, we said, has played the biggest role, should have a work plan, and also take care of the national public health programs, organize the quarterly and annual performance reviews and the research, and also take care of the quota improvement activities. Next. So regular support supervision is very important, already mentioned, focusing on technical and also integrated. There has to be a balance, but more so for the technical to improve the quality of services in the lower level facilities, but also the program-based support we have. Then monitoring and evaluation, also need to be taken care of by the community health department, establish a regional database, and also do the disease surveillance activities in the region, take care of that one as well. Districts they do implement the government programs. That's a well-known thing. They also have to do the partner mapping, conduct quarterly performance reviews at the districts and the facilities, and also submit these reports, share the reports with the regional referral hospitals, and participate in regional planning and the coordination meetings. Next. Partners, we appreciate the partners in the region. They should participate in the planning and implementation process at regional level, building capacity for monitoring, supervision, coaching, and mentorship, and any other area, and also share reports of their work in the region, during the regional, through the regional referral hospital community health department, and participate in the Ministry of Health, regional support, any other activities that take place at the regional level for the district support. Next. Funding mechanism. Funding is largely government of Uganda has the responsibility to provide the resources for this. So far it has been 5% of the PHC, and we hope this can improve with time because the responsibility has increased for the community health department and the regional referral hospital. Next. We want to appreciate PEPFAR, which has come on to support this in the region. All the regional referral hospitals now have earmarked funding through CDC and USAID, basically to operationalize the regional support to the districts, and we hope this will be a starting point for improved funding for this idea. Next. MOU have been signed by the respective hospitals. Partners expect to add on this to continue with the support, and the regional referral hospitals, top management and leadership should build capacity for the community health departments to mobilize and manage resources for this purpose of supporting districts in the region. Next. Monitoring and evaluation. Chair, I'm taking just a few minutes to conclude. This is very, very important. The regional referral hospital community health department, you should take the responsibility to collect, analyze, and produce reports on the key performance areas in the region. That capacity has to be built so that we don't wait for Dr. Sarah to come here and present, but we generate our own reports and have them properly used. Again, the regional hospitals will be facilitated to access DHIS too, so that it is able to have data available at its disposal, and also facilitate the performance reviews to be more useful and effective for their purpose. Next. Support regional-based supporting interventions. There are a number of these. There are programs taking place under Global Fund, HIV/AIDS program, reproductive health, maternal and newborn health, quality improvement, immunization, emergency operation, ambulance. Ambulance was mentioned here in the morning, and there will be, I think, a presentation tomorrow. All these are regional-based support interventions, so that they need to be monitored in an organized manner, and they inform the process of planning and the progress being made. Next. Laboratory services and integrated disease surveillance. So the community health department should have a capacity really to look into all this and put it together to guide the region and the districts for better planning and implementation of government programs. There's also regional-based institutional support taking place. We have the regional blood bank, the medical equipment, maintenance unit, national medical stores, and others that we need to take care of in one way or another if we are going to improve regional-based performance. Next. So the impact of these interventions, they need to be more appreciated, as I've said, and the mechanism for joint coordination and support be provided for the region. And the monthly, maybe monthly or quarterly reports again can be decided. Reports should be available from all these different actors at a regional level, and they should be analyzed and then synthesized to give the status picture and also guide on the future plan. Local leadership authorities, and including districts and urban authorities, they need to be, they need to organize. That's another key point. The districts, the facilities, also need to organize their appropriate performance reviews in the districts and even in health facilities. And so that there's more opportunity for use of data and coming up with more useful guidance on planning and the coordination of regional activities. Next. I'm done almost, I think. These are the key performance indicators being proposed, and we shall need a lot of input from the responsible different actors. We need to be, I think, at par with regional performance reviews and the support supervision being conducted. I think this should be tracked, including quality improvement, implementation, and the regional program-based interventions, and the district league table indicators. They need to be, I think, be appreciated and be analyzed regularly, and the key actions taken for improvement. Next. Performance reviews. Chair, this, I think, let me just end with this.
It's okay, Doctor.
Yeah, this is the performance reviews. We need them. They must be there. They should be properly organized and focusing on the key performance areas. I know there are many things taking place in the region, and one may choose to come with the bias in particular area, but I think the key performance areas should be the areas of focus for the performance reviews. And we build consensus on undertakings for improving quality of care. Performance reviews should be regular, quarterly, and by level from the region to the districts and health facilities, and should be organized. The rest of the regional cases should be taken care as learning sessions, which can be for the programs. TB, mention it. But if you have so many performance reviews for TB, for what? Yeah, I think it's going to cause fatigue. The last bullet, frequent and uncoordinated performance reviews are likely to cause fatigue and unwarranted duplication. And so I think also they may cause confusion. So let's have one organized performance review take stock and care of all the different interventions. You can have 2 days or 1 or 2 days or more, but really addressing all the key areas and getting the results, expected results. And lastly, yeah, you have to come up with a format. You must agree on the format. Not everybody reporting the way you want. So you have to see it, and I think we are going to have a proposed format, and then that all the different key stakeholders have to follow so that it is not, you minimize confusion. DHIS too should be the main source of data, and I think access to this should be really worked upon, especially at the regional level, so that you can easily know what is taking place in the whole region. We need a program again, which is, I think, which is also standardized. Not people. You can of course make adjustments, but by and large, the program should be talking to each other so that whatever you do is something that is comparable. Chair, I thank you so much. The conclusion is there for us, but I want to thank you so much for giving me the opportunity, and sorry for the long, many slides.
It's okay.
But I appreciate it.
Thank you very much, Doctor. Can we give him a round of applause as we wait for the next presenter, that is other than Dr. Rabin Rabe from UNICEF. Is he around? Doctor, are you there? Can you come up and you take the podium? Is he around? Is Dr. Rabin around from UNICEF? I think members are consulting. Yeah, I have been informed that he's going to make his presentation online. So I request the technical staff behind the machines to help us connect Dr. Drave to the audience. Someone is making a phone call. He's being contacted as we wait for his response. And if he's following us, we are giving him like only 15 minutes. Then thereafter, we'll go for the discussion. The technical team are still consulting and is going to make presentation on the status and functionality of general hospitals and health center force. Yeah, we are being connected. Thank you very much. Actually, the technical team are consulting, and it seems Dr. Rabin is not ready to make presentation now. He has requested that we allow him make his presentation in the afternoon at 2. So we are actually requesting immediate substitute by the name Yoweri Idiba to come and take us through his presentations, if he's ready. There he comes. You can take the podium, and Yoweri Idiba, we are giving you 15 minutes. Actually, Idiba Yoweri is going to make presentation on the status of health sector's performance in Acholi sub-region. There he comes. Since you've delayed a bit, we are still giving you that 15 minutes. So you can take on from there.
Thank you, the chair of this session, the invited guests, and all participants. Good morning. I'm called Yoweri Idiba. I'm the Assistant District Officer, Gulu District. I'm presenting on the status of the sector performance in Acholi sub-region. During this assembly. Next. Acholi sub-region has 9 districts as per last previous financial year, but now we have 9 districts, including Gulu City. Gulu City was carved from Gulu district, that's why you're seeing that big red color. Next, our layout, I'll look at the background, the profile, financing, the local government assessment, the progress in the broadcasting issues, the causes of morbidity and mortality in Acholi sub-region, and our progress in service delivery, challenges and action points, and key partners who are supporting us in this region. The vision, mission, and mandate. Our mission in the health is the health product and a productive population that contribute to the socio-economic growth and national development, with a mandate to provide highest possible level of health service to all the people of Uganda through delivery of promotive, preventive, curative, and palliative and rehabilitative services. Our mandate is to coordinate, plan, and supervise, organize human and national resources, build the capacity of staffs. Our goal is to increase productivity of the population for increased competitiveness and better quality of life for all. And also we are following the Sustainable Development Goals 3, 5, and 6 as listed there. And the objective in all is to improve the population health, safety, and management. Next. This is our Acholi sub-region profile. I told you we have 8 districts in previous year. Gulu City is within Gulu district. And those are the populations we had as per last financial year. In Acholi sub-region, we have 17 health sub-district or constituents. Where there is red, one of them are not functioning. One is having a center for or hospital. The rest don't have. And then we have 132 sub-counties, including town councils. We have 600 parishes in our region. Next. And then the government, sorry, a bit backward. Back. Yes. We have 4,182 villages, and we have 315 reporting facilities. Others are not reporting, especially the clinics. So we have not included them there. And the ART side, providing ARVs, we have 84 sites, government and private, with only 8 hospitals. Majority of them are in Gulu, and those are both private and government. Next. These are government facilities. We have a total of 227 government facilities, with only 1 regional hospital, with two district hospitals. That is Anaka, Gulu, Kituguma, and UPDF here. And then we have 8 health center 4s and 75 health center 3s, majority health center 2s, which are 138. Next. Our human resource, our staffing as Acholi sub-region stand at 67.5%. Most of the gaps you are seeing in all districts, except Amula and Gulu, where we are at least 80%. The critical cadres needed are medical officer, nurses, midwives, laboratory staffs, DHOs. We are having acting DHOs mostly. We have also assistant DHOs are not there, and aesthetic officers who are supposed to be in the theater are not there. And then we have clinical officers, and then dispensers are missing most of this district, including now support staff, which form a big population. Next. Looking at the health financing in Acholi sub-region, we get our funding mainly from central government transfers, donor support, Ministry of Health, Global Fund, Gavi. We have the off-budget support from our partners who are here, RIGHTS, TASO, Uganda Protest Medical Bureau, World Vision, Soltel, Avis, Accord, and other partners. We have also support from social corporate responsibility, like the banks, MTN, Stanbic Bank, Pride, and others. Then last year, we get our financing from local government, local areas revenue. That's where we get the funding from. Looking at the PHC allocation per district, per level, there is a variation in the PHC allocation, though they have the same level. Looking at hospitals, we have Anaka Hospital and Kituguma Hospital. There is variation as you are seeing. 518 million versus 420 million, Noya, Anaka Hospital. The center force, as I told you, there are 8. We find out the highest gets 95 million, that is in Amulu. The lowest is getting 60 million, that is in Omoro district. When we look at center 3s, the highest is getting 40 million center 3, and followed by Gulu City, that is 31 million. And then the lowest itself is getting 12 million in center 3, that is in Omoro district. Then we cut center 2, the highest is getting 20 million, that is in Noya district, followed by the city, 15 million, and then the lowest is 6 million, that is Omoro district. And then district health office, the highest is getting 85 million in DHO's office, and the lowest is getting 43 million, that is Gulu City, followed by Gulu district and Omoro. So the variation is there next. Under the local government assessment 2020 scorecard, we thank Noya district for giving us an example. They have passed the local government assessment. They are ranked number 25 out of the whole district with a score of 50. And most of the areas which were assessed, they passed them, except the environmental and social safeguard and then human resource development. But the rest, they are good at least. Though good also tried, we need to check example from Noya district, how they are doing it, so that our Acholi region perform better. But most all the districts were among the last districts, including Agaga with a score of 9. So we need to improve in this, and this is where we need to strengthen very well under the right support system. Next. Progress in the cross-cutting areas. We have HIV. Our objectives to mainstream HIV activities in local government using the 0.1% budget allocation. The concern was little done to create awareness of HIV in local governments. And what we did last financial year, HIV awareness meetings were held, condom dispensers were put in all places required, and safe male circumcision was done. We shall look at the indicator. Gender issues of access was critical, and we had improved patient care, access, diagnosis, screening, treatment. We had also youth-friendly services last financial year, and immunization also was core of the issue using the government funds. Environmental issues was issue of the disease outbreak and facility infections, facility-based infections. So what we did to improve safe water and good sanitation, health and safety activities, and waste management. Waste management, we had a company supported by rights to make sure that they pick most of the waste from those facilities. Disability inclusiveness was an issue, but we had to achieve by promoting the disability guideline, which were issued by means of gender. Next. Our priority was to hold district and regional quarterly performance review meetings and regional assembly. Progress, we have been holding district reviews, which is good, but we had been having irregular regional quarterly review meeting due to funding gaps. And then we are now holding the first ever regional assembly, which is here under the leadership of our Dr. Rima, the hospital director. He made sure he spearheads this program. Thank you much, hospital director. Then we had to develop integrated district health plans and budget inclusive of CSOs and IPs. Our progress, means of health has trained districts with few partner involvement in the integration. This one has not properly kicked off, but we need it to continue. And then we had joint integrated support supervision using next strategic guidelines. We are on track, catalyzed by RBF. This is a program and AMUCHIP. The new guidelines were given yesterday, and we are going to enforce them seriously.
Presenter, you are remaining with 5 minutes.
Chair, my presentation is big and is for Acholi sub-region. You allow me to have some more minutes.
It's okay.
I'll pick. Thank you very much, Chair. Under human resource, our priority is implementation of new staffing norm and structure. This is not yet implemented. And then declaration of acting position as vacant to get substantive person. This one is in progress where the service commissioner functional, but we have a big gap in Acholi sub-region. Last year was acting, so it was a big gap, yet there are more other vacant positions, so the stress was too much. But I thank this year chairman had to intervene, and at least the medical officer from our watch came on board to help me at least. Thank you very much. Staff attendance, action taken. Last year, presentism was at 46% last year, but 2019-2020, and this last year was 2021-2020 was at 47%, an increase of 1% despite the COVID. We have tried our level best, and off duties has increased, leave has increased, and the request has increased, but absenteeism are reduced from 20 to 10% because there is harmony at least now in the Acholi sub-region. What we do, we delete staff from the payroll, they face reward and sanction committee, and also we have strength and support supervision to link it to reward and sanction. Grievance redress, we are doing it. Where the staff accommodation is a challenge, we are trying to make sure that they share with the same sex, they share the rooms, so that the service can continue and reduce absenteeism. Next. Under disease surveillance, we were to invest in a community-based surveillance approach to avert epidemic disease like Ebola, COVID, malaria, TB. It is in progress with emphasis on COVID, vaccine-preventable diseases, malaria. VHT guideline has been distributed to all districts in Acholi sub-region, though they bring us more guidelines, and the reporting at least has improved, as per the commissioner's presentation also. Also to train health workers in COVID-19 management, IP surveillance, which we have been done as per the presentation. Thank you. Continue. Quality and safe medicine availability. We are to improve patient records, accountability, and reduce leakage. Slow progress with electronic medical record rollout to all facilities, only at sites where they are giving RVs. That's where the system is working. Health center tools, not yet. And the other department within the facility, they are not yet functional. Then increase reagent availability and supplies in all laboratories. The range of tests and volume has increased, but the funding has remained the same. Then under priority number 3 was drug stock out in all facilities. Here we are looking at the progress. There is increase in code line budget, and what we are doing now is reallocate the medicine. Wherever they are more in excess, we allocate under support of the regional hospital. And then drug audits in health facilities, there's good progress using support supervision, performance assessment, and recognition. Under infrastructure, we have to provide necessities: water, electricity, internet, sanitary facilities. This is slight progress due to limited fund, but partners supported us with ICT, solar, water in some facilities, latrines and fridge from the Ministry of Health, some incinerators from our partners, and placenta pit. Upgrade of underserved areas, this is ongoing, though we need more. And then functionalization of and rehabilitation of Center 3 and 4. The focus is still on hospitals, but we thank IP, Rights in North, they have supported Kitugum and Pade. The theater and maternities are wonderful. We shall see them later. Then support transport system in local government. Ministry of Health has given us vehicles, motorcycles, under Gavi, COVID, TB program, NTD, and under partners. That's a good achievement. Next. Other gaps still, we have Health Center 3s without general wards and Health Center 4s. And also we have Health Center 4s without standard laboratories, which is a big challenge. And in all facilities, we don't have motorized water system. We have been using the water tanks, but now they are all broken. And the challenge of carrying water in the head is a challenge now, so we need more. That's the gap we are having. And also an issue of sanitary facilities, and then staff accommodation, solar, and the ambulance services. Not all this we have ambulance. Next. Communicable and uncommunicable disease. Our top causes of mobility is malaria, standing at 42% for Acholi sub-region, followed by cough and cold at 15%. Then others follow, which include diarrhea, gastrointestinal disorder, intestinal worm, skin disease, urinary tract infection, and others. Next. ICT. The top cause of admission is still malaria with 48%, followed by pneumonia 11%. And the rest, as you see, they are still affecting us in admission in all facilities. Next. Top cause of death. Still malaria is ranked number 1 with 13%. Last year, we lost 256 male and 209 female due to malaria. This was followed by pneumonia, cardiovascular disease, premature babies, and respiratory distress, and others, like sepsis is also still a challenge in our Acholi sub-region. Next. Non-communicable disease. When you look at district, hypertension is still high in Gulu, where the city is. Those are the diseases we get. Even diabetes, where there is a city, there is high also, and then depression disorder and epilepsy. Those are the conditions we have which are high. Cancer is also here, but I not include it, but it's among those non-communicable diseases we are trying to battle with our partners. Next. Progress as per the program. Quality of care, performance. Our maternal deaths among 100,000 health facility life births, we stand at 109 in Acholi sub-region, which translates to 62 mothers died. That is the whole birth. Last financial we carried to heaven. And then the children who died, the prenatal deaths per 1,000 life births, it is at 23 per 100 life births, which translates 1,320 babies died. And then our maternal death audit review is high with support from our partners. And then perinatal death review, we stand at 63%. We still with support from our partners in the region. Next. Under the maternal and child health review overview, per region, the OPD per capita in Acholi sub-region stand at 1.9, translating to each person at least visit the facility twice in a year. And then our ANC first visit within 90 days, it is at 34%, Acholi sub-region. And then ANC first visits, those who are pregnant who go there at least 4 times, they are 56%. Delivery, we stand at 66%. And consider those 3, we stand at 59%. And immunization for children, DP3, we stand at 87%. Teenage pregnancy, we stand at 22%. With a total of 18,243 in Acholi's region, we are teenagers below 19 years. Even we had others 9 years, they are inclusive in this. And then deliveries, teenage pregnancy was 21% of total delivery in Acholi sub-region. And then maternal deaths, 7 out of the 62 were those teenagers below 18 years. Next. Abortion and family planning. Abortion cases were high in Gulu because of a city and institution available. But when you look at 38% of the abortions were teenagers. And then 22% of post-abortion of women received family planning. Majority of them, as per this, you see, they are not receiving family planning after post-abortion care, which is still a big challenge, and we need to address it. Next. Immunization. Actually, sub-region, all of us, we are not meeting the target of 95%. We are at 80 in all the antigen selected. Next. HIV status. Invited guest. As Acholi sub-region, we have 73,425 clients active on ART. Majority of them, 64% are women. Children are 4%, and our retention stands at 62%, which is a challenge, and our viral load suppression at 86%. So we are not meeting the target of 90-90. Next.
Presenter, we are adding for you 3 more minutes.
Next.
You can conclude.
Our HIV prevalence between 15 to 49 years age and TB. Our HIV prevalence is the 7.1% Acholi sub-region, with highest in Gulu at 12.4%. The TB situation, our TB detection rate is at 86% Acholi, and our TB success treatment rate is at 81% with cure rate of 65%. Gender-based violence is more in Omoro, followed by Lamo, and then in Pade. But at least it's reducing most of the districts, except Omoro and in one of the districts of Agago. The GBV is high. Next. This is LHS survey. Male circumcision, there is an increasing trend. We have registered in post since 2018 to 2021. And good success is in Agago, is in Ketogum, Gulu, Noya, Omoro, and then Pade have reduced, and Lamo and Amuru. Next. Malaria burden. We stand at 59% of the malaria burden, 54% malaria burden, with admission rate of 32%, and the total death ratio proportion at 27%, and positivity rate is at 62%, and the malaria deaths in inpatient starts at 46%, and the testing, malaria tested using RDT, we stand at 80%. Next. Sanitation, next. Our coverage of improved sanitation in Acholi under the deployment of LQS, 4 districts of Agago, Kitgum, Lamo, and Omoro had a decline in there, below the target of 40%, and Gulu, Noya, Pade had increase in performance, at least above 40%. Next. Wash performance, percentage of individuals who wash their hands with soap and water in the community, we stand at 72%, and percentage of household with safe water at 83%, and then percentage of household with latrine.
You are remaining with only 1 minute.
Stand at 88%. Next. 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 Challenges and action point. Our challenge is still medical equipment and facilities are lacking. Drug stock out is still a challenge. Staffing up, supervision issues, dilapidated infrastructure in all facilities and all levels. Next. Next. Not all sub-counties have a Center 3. We have low immunization coverage, as seen in the presentation, high maternal and perinatal death, low ANC first trimester, high teenage pregnancy, low retention on earth. Next. Capacity building up under Acholi, and then low patient satisfaction, where we are focusing on mentorship, coaching, and supervision, and use of scorecard. Non-functional HUMIC, we are advocating for more fund for selection and training of HUMIC, and then low RBF absorption, we want to embrace teamwork and quality improvement. Next. Next. Keep it on the next. These are the infrastructure supported by Rights North Acholi in Padre Center 4 and 3, theater and maternity, including the latrines and janitor houses. And then this one was in Kitogum Health Center 4, theater and maternity, and including the janitor house, the placenta pit, and the solar, to make sure the place function. This is under your gift. This is Omoro. That is under your gift support, and then the other is DGE Gulu District. That's the Peta Center 2. We use 2 phases to construct it. And next. And then under PHC and WUSHA, up is PHC funding, sector development grants, and then under here is partner support under total community total-led sanitation. They are supporting us. WUSHA is supporting us in the community to make sure people have latrines, have hand washing facilities. Next. We acknowledge the government of Uganda. We acknowledge also the district leaders who are here and those who are on virtual, the district team, the frontline health workers, the beneficiaries of this program, the invited guests in the house, and the organizers.
Okay.
Most of the God, Almighty, who is the most powerful. Thank you very much.
Thank you, Presenter.
For God and my
Round
country.
of applause. Thank you very much, Yoweri Idiba, His Excellency. With that, I am going to invite participants for the discussion, and it's going to last for 30 minutes. Then thereafter, we shall break for lunch, and Michael will take over from me in the next session. That will be from 2 to 3. So may I now invite the participants to give in their views so that we also chart a way forward. So the floor is open. Dear participants, the floor is open. Yes, a gentleman there behind.
Thank you very much, Chair of the session. My colleagues, the participants, in your distinct capacities, I have an observation, especially I'd want to hear maybe a response from the Commissioner, Dr. Martin. We have seen the presentation from the region, how we are performing. Among other things that I would want to raise for discussion in this assembly, it is the functionality of our facilities. I would like to start with the Gulu Regional Referral. We are here seeing very good statistics being presented. But when you go to the facility, there are a number of things that needed to be actually addressed. From time to time, those that have been going there for medical attention, this is on record, everyone knows. You'll go to the facility as the regional referral. You would only be able to see a medical worker, only to tell you that You go and test outside. After testing, bring the result. On bringing the result, they will describe for you the drugs. Go and buy outside. And here, our statistics are very clean. That is, we have tested this number of patients, we have treated this number of patients. Yet all this treatment, all this testing, we are done outside and we are being paid for. But now we are presenting statistics that we are being done freely. I don't know that you know that this is happening. It is very sad. And as we are here for this joint assembly, these are some of the issues that we should actually deliberate on without fear or favor. Our people are really suffering. And when we come for a workshop, when we come for assembly here, we are very clean with our data. Yet they are all fake data. I could say that rather. It is really very sad. Then to our health center force.
Let me draw your attention.
Yes.
I want to beg the participants that let us be straight, go straight to the point, and be brief.
That is a very strong point. They don't want us to tell them. So the issue is that really, what the functionality, the standard of our regional referral, if even the testing kit for malaria, it is not there. Treating malaria is defeating the regional. And our people who move outside, move to these public facilities, especially to the referral or public facilities, they go there because they don't have money to go for these private facilities. That is my concern, Chair. And I would want to hear from the ministry, if they know that this is happening, then from the Director, Guru Regional. Thank you.
Thank you very much, Honorable Burlington Pangwech. May we hear from RCC, then we come to Honorable RDC for Lamour. Mr. James Kidega Navinson, RCC, you're welcome.
My concern is to the commissioner from Ministry of Health over the issue of manpower, especially at the health centers. From the submission of the Director of Guru Regional Referral, he was saying doctors and other health staff are not motivated to go to the rural health centers. But even here at the city, there is still a big problem. I remember when the Sinovac vaccine was brought, arrangements were made for teachers to be vaccinated at 2 centers at Laibi, St. Joseph's College, Laibi, and Sacred Heart Secondary School. Now, when this program was to begin, we realized that for that to be done, we would need to close all the health centers within the city for the staff to go and perform that duty, which we found it could not be done. And therefore, we had to resort to vaccinating teachers at only 1 center, which delays the process. I remember 2 days ago when we had another meeting, we were being warned of consequences if you allow your vaccine to expire. Now, if we make arrangements and then we don't have health workers to do that, I think really the issue of manpower should be really handled seriously. I know that, of course, at times the Ministry of Public Service has its ceiling, but I think something has to be done for us really to succeed. Thank you.
Thank you very much. RCC Gulu City, can you take the microphone to RDC Lamour? Help you.
Thank you very much, the chair and the organizer, for giving us this opportunity to share and trying to improve. I know our basic reason of being here is to share together the pain that the health workers are going through, and also our contribution as leaders. What do we see and how we will move? My concern, which I think should go to the challenges which I have not seen. There's a tendency in Acholi sub-region, almost all the health centers, this health center 2, health center 4, there's a problem there. I don't know whether on Sunday and Saturday, people are not sick. When you move to this old center, you find out all of them are closed. And that's a time that people always die with those diseases because they run there, and also the referable system must also be looked at. Our referable system from the health center 2 to health center 4 to referral, that system there doesn't work. Who picks? Because somebody said, okay, now, I remembered in Putira went there and found there was a pregnant lady who was about to deliver, and these people couldn't handle because she has to go through operation. And there was no transport, there was no coordination. The lady was just lying there. I think this must be worked on. As partners, you see those sensitive areas so that you batter the different there. Finally, the resource allocation. I think duplication of works of outreach system, we need to coordinate also. There are certain outreaches that government is also sending fund. Our partners also are putting in fund. You find out the period, the calendar of the health centers are almost the same, with the same resources. So this must also be looked at. As a district hosting refugees, there's also a big tension between the host and then refugees in the consumption of what? Of drugs. So I think this must also be looked to, because they said refugees and the host should work in the same facilities. But you find out our partners who are, like, for example, some, I will not mention the name, but this is what I got on the ground. They tell you, where are you from? This one is a refugee. You first go inside. You are the host, first remain. And sickness doesn't wait for who is a refugee and who is a host. So these are issues that we need to share together and work as a team and correct. But I see we are going to the right direction if we combat together, as we sit together and see where is our contribution. As leaders, as government, as partners, we'll move forward. I think we are different from 1980 when you see the medical facilities are now. We can be safe. Thank you.
Thank you very much, RDC Lamo, Chidega Navinson. And we have 2 people who are online. May we allow them give in their submissions? And we come back to the audience, to the members. Yes, please, proceed.
Please speak up. Gulu Biostat team, please speak up.
William, we are ready to hear from you. Please go ahead and talk to us. William Onyai, we see you online and you have a submission to make. Please proceed.
Oh, yeah. Maybe we come back to the house. RDC Chitgum. Then we move to Mama behind. So we'll be number 2. The third person will be this gentleman, and the last one there behind. I'm not seeing you well, Bishop. Yeah. And we are going to move in that order.
Thank you, Chair. My concern goes to the Commissioner from Ministry of Health. The outdated policies, which is affecting health centers. Why are they stuck to that? Because if you look at the existence of Gulu referral hospital, it could have been on a population by then. But now the population has expanded, but with no expansion in health services. I put a case in point for our General Hospital, Kitgum. The number of patients Kitgum is seeing now, including the catchment area, quickly need attention of Ministry of Health. Because this has brought shortage in drugs, where the other gentleman was very, very clear. People do tests, but there's no enough drug. And also fundings to the health units. It is not enough, which they quickly need to look into that and revise their policy. Chairman, I also want to thank the organizer of this workshop. It is the first of its kind here in Acholi sub-region, but I also want to echo myself to the speech of the Minister for Northern Uganda. This kind of annual health assembly was going on in West Nile. And it was an initiative of DHOs of that region. I advise that we shouldn't much depend on the funding, with or without. This should now be a beginning for us and now a high opener. It must continue. Thank you.
Mama behind there. We'll move in that order.
Thank you, Chair. My name is Margaret Mugisa. I work as a project manager with AMREF Health Africa, commonly known as AMREF. I want to add a voice to Yoweri's presentation. He identified one of the challenges in Acholi sub-region is drug stock out. Indeed, it is true. If you relate it to the statistics that he highlighted, I can single out one, especially when we focus on teenage pregnancy. Chair and members here, you'll agree with me that family planning commodities are nowhere in our health facilities. Health facilities are struggling with family planning commodities. And no wonder we are having such high rates of teenage pregnancy. However much people will sensitize our young people and they cannot access family contraceptives, I'm worried we may not change a lot because they need them. Condoms, getting condoms is also a struggle. I think with the commissioner here, this is an issue that we need to address. Our health facilities are lacking essential drugs that can help the health worker provide quality services. Thank you.
Thank you very much. Gentleman, can you pass the microphone to him?
Thank you very much, Chair. I'm retired Colonel Fearless Oboyoyat, Chairman for the district local government.
No, this mask can change really the face of people. Can proceed.
Yeah, mine is going, I think, direct to the Commissioner, Minister of Health. I'm talking about Pade. First of all, I don't want to talk about medicine or whatever. The first thing is Pade has suffered for 21 years without district hospitals. Pade, to connect to any else referral center, you go more than 100 kilometers with bad roads. Our mothers and children are dying on the cost of transfer to get health services. My humble request for Pade district as of now, it's not even easy to battle this coronavirus which has affected the whole world. I'm giving an example where a woman was badly off and she was referred to Gulu District Referral Hospital. On reaching here, there was even no space because the referral hospital was overwhelming. The woman was nowhere to be put. She was taken back and she passed on. Those are some of the challenges which the district have. I must thank the director of Gulu Referral Hospital in his speech, which said minor treatment which could be treated from health centers are always referred to the referral hospital. I think the majority of the referral cases come from Pade, because Pade, even if a nail pricks you, there's no way they can operate and open. They are always referred to the referral health center in Gulu or Kitgum, which is over 100 kilometers away. My humble request is the commissioner at the ministry level, we are requesting if they could really be considered and have a district hospital. The second one is something which I don't know whether it is intentionally left quietly, but the district has the majority of nodding disease children who have nodding disease syndrome children. And you find in a family, a parent may have about 4 or 6 children affected with nodding disease syndrome. And these parents have no time to go and even do some cultivation to feed these children. Because you go out a bit, you find one of them has disappeared, you have to look for that one, and most of the time they're occupied looking after these children. And they have no way to get engaged into any other activities to make the family even fit. My humble request is, if it is possible, we are requesting maybe if a rehabilitation center could be built for these children, so that at least it gives a relief to the parents who are looking after these children. I submit my request to the commissioner to forward it to the ministry.
Okay.
Thank you.
Okay, thank you very much. Bishop, this is the last person, is on this side. Oh, and finally, we'll wind up with these two gentlemen, and the last person will be Mama in front, putting on the white mask.
Thank you, Chair. Thank you, the organizers. I am George Uchan, Secretary for Health, Amuru District Local Government.
True.
Thank you for the wonderful presentations. However, I think we need to adjust a bit and give them more time to present so that we get the data, because we are hiring them and not picking all that they have prepared for us. That's
True.
my humble request.
True.
One, I would like to submit that the referral hospital has to extend beyond waiting for this day, because I know there are districts that have come into this review without conducting their district reviews. So I think before we come for a meeting of the regional level, it's important to consider that all districts have done their reviews and the data they are presenting is factual and real. Secondly, I think I appreciate that as the Secretary for Health, at least there is some good funding in the Health Department, although not maximum. However, I think the partners who are supporting us are doing a great work. However, as the partners work in different districts, there is always need for coordination to sit together, maybe on quarterly basis, and analyze what they're doing in different places. I think this will also help us in seeing the budget that they have allocated for the districts so that we work with knowledge. I thank you so much that Amuro district is working at least at over 80% of the staffing in the health department. However, with the emergency of COVID-19, our staff have already been taken to the point of entry, of which it has taken so many staff from the district and have not been replaced. I hereby appeal to Ministry of Health that it has taken time that we have lived with the COVID-19. It's the high time they could recruit more staff for the port health or points of entry and relieve the staff of Amuro that went there as emergency. Thirdly, I think it's also important for us to see how to upgrade. Because like a case in Amuro, which I believe so many health centers have been upgraded from health center 2 to health center 3. But the supplies and the structures are not matching what is in place. Okay. So I think the ministry has to do that. As I go to end, as somebody put it, next time we are organizing this regional meeting, it will also be good to take a tour of some of these facilities and understand whether the data is matching what is really on the ground. Thank you so much.
Thank you. As I've said before, pass the microphone to those three participants, and I'll draw your attention here. Thank you. Let us really be brief. I'm giving you 2 minutes each.
Thank you so much, Chairperson, and all the participants here present. My name is Aroy Christopher Obol, District Chair, Kitgum. In the first place, I want to really thank this August Assembly for the moment that has been created for participation of the people in this sub-region across the board. This is a big landmark. Looking back at the presentations that have been given by the previous presenters, I just want to quickly touch on one concern, which I think is a common concern for each and every sector in the sub-region in terms of our health care. My concern is about the routine delivery of drugs and essential medical supplies by the national medical stores. This is perpetually, Mr. Chairperson, inadequate. After 2 weeks after delivery, you'll find that the drugs are not there. And this culminates to the point that my other brother brought up in this August Assembly. My concern is, can this August Forum, can this August Assembly provide an answer to this very delicate concern? The Commissioner for Health is here, and other stakeholders are here. Let us go back with some answers. Thank you.
Let us also come out with recommendations as well, if possible, where necessary.
I think, in the first place, we need to consider the catchment areas that our drugs are taken to. For instance, my RDC from Kitgum indicated that Kitgum Government Hospital has a very large catchment areas. And for that matter, when these drugs and medical supplies are taken, there is no consideration of the number of population.
Noted.
This is taken care of.
Noted. Thank you very much. The next person. Then finally, we come back to Mama.
Thank you so much. Thank you so much, Chair. My name is Charles from World Vision. I want to thank everyone. I have 2 minutes, and I've already used some seconds. I want to observe the protocol in this house, and I want to make it clear that the director, Gulu Regional Referral Hospital, said this is a voice forum. And I want to say health is a collective responsibility for all of us who are here. There is a reason why we are here. So I'm calling all of us to take part. There is teenage pregnancy issue, which I don't know whether this is our part for all of us who are here. Friends, this is a battle that has been on for years. And I think we need to take it up beyond this forum and ask, what can we do? Religious leaders, cultural leaders, locally, what can we do about the situation at hand? Can we uphold the law and apply it without compromising? Our girls have been subjected to highest level of vulnerability. We need to do something. We need to wake up. Every girl deserves the best in life. And it begins with us who are here, and I'm happy the information has been shared. Yesterday, I've been here, this is my third day of being this hall. There is a financing of health sector, and I was informed that 30%, that the budget for health sector is 30% funded by the government and 70% by the donors. I'm worried. If the donors close it today, what will be the state of the health sector in this country? I am thinking that this is a democracy issue we should be able to move forward. Chairman, that we want the government to take lead in financing health sector and have more percentage go to it than giving it to the donor. It's like you building, you are marrying, and then you take another person to take care of your wife. I would call the government to take more percentage in funding health sector. That's the commitment we would want to see.
Correct.
And then, Chairman, I want to appreciate what my brother, Dr. Yoweri presented, the issue of absenteeism. I want that to correlate absenteeism and drug stock out. This is discouraging. You can go to the health unit, there are no drugs, and how can you just go and sit there? Patients are coming, you feel you don't have the answer to give people. What are you doing there? So let us correlate the two. Drug stock out and the presence of the medical people. They are there to give a service. If you cannot give a service, why should you be there? So I would want, this is something we need to correlate and see how do we address this as government and be accountable.
Okay.
I think because of time, let me leave it the rest to other members. Thank you so much.
Thank you. Mama here in front. You first bring to Mama here. And we'll go back to sister and my mama here. The RPC prisons. There are some comments here I want my colleague also to read so that we wind up with those two honorable members. Yes, Honorable RDC.
Thank you so much, Chair. I'm Susan Akanya, RDC Agago. I would like to talk about support supervision. Support supervision is not a visit to a health facility. It's a mentoring process. The supervisors that move to health centers to supervise must be able to work with the health workers there and mentor them, such that by the time you're leaving, they're better than you got them. We are not doing this. That's why we have gap in the health service delivery.
True.
Then secondly, the issue of human resource. The most valid asset is human resource. So when there's a gap, how do we expect one to perform? Health workers are just like any of us. When you get to a facility, say at 8, you're attending to patients. By the time the 40th patient entered, are you still the same person? You need a rest, you need a break. So we don't need to blame our health workers, but we need to fill in gaps that make them not perform to the expectation. When we look at drug stockout, there is an attitude that when you see a truck delivering drugs, you take all the family to the health facility to get drugs to go and keep home. So we need to talk to our people that you don't have the capacity of drug storage. Take the drug that you need. That's what's happening. And then we think that the best service is at Gulu Regional Referral Hospital. Other health facilities don't give you the best service. That's why you see drug stock out at Gulu Regional Referral Hospital. Even the issue of the testing reagents and all those, it's because we don't believe in other lower health facilities. Then lastly, another challenge. We are upgrading health centers fine, but they take long to complete constructions. most of them are behind schedule, and it's affecting service delivery. Because if these health facilities are upgraded, the human resource would increase, and the drug supply would increase. So if they take more than the time they are given to complete, it affects the health service delivery in our sub-region. Thank you, Chair.
Thank you very much. At least for Gulu Regional Referral Hospital, I know there's really great improvement. And we thank you so much for the good work you are doing. Dear members, we have some participants who are also following us online. And I will request that we take 2 or 3 comments from them. And we wind up with the sister and RPC prisons. Just for a minute. Yes, please, and proceed.
Thank you, Chair. We have a comment from Victor Rwengabo. I quote, according to the presentations, HIV and AIDS is no longer among the top causes of illness or death in the region. It sounds great, if true. We go to the next comment. From William, attending from Gulu. Plan more support to the community. Engage the community. We can prevent 70% of diseases at the community level. Another submission from Judith.
If possible.
All submissions from the participants attending live are not new challenges. Most of these are already known. It's time we suggest solutions and make proper use of data to check progress. Thank you. William Tabazi comments, point of information, let participants be put to know that there has been marked improvement in commodity and medicine availability. In 2018, the region was averagely stocked out at 40% of essential medicines. Currently, the stock out is less than 25. A few commodities get stocked out from time to time, but big proportion of supplies are getting more available. Wow. For ARVs and TB, we have ensured 100% availability for the past 1 year. I think we put up a till free line or a call center for affected to call for cases of stockouts. Wow. To bridge a commodity gap. Finally, William Oloya proposes build-up events for the regional assembly to include district level review meetings to validate health data. William continues to clarify, political and technical leaders should pay keen interest on order versus supply fulfillment. This will exonerate NMS. Let district inventory officers be tasked to provide this report immediately after NMS supplies. Second, have medicine management call center or toll-free lines to address medicine management-related issues. Political and technical leaders conduct quarterly supervisions on commodity management, and we can mentor them on key issues to look into. William from Rights.
Thank you very much. Our audience who are following us on online, because of COVID-19, this house cannot actually accommodate all the participants. That is why they're trying to give their comments through online. Thank you very much. Can we have a sister and RPC to give their last submissions?
Yeah, thank you, Chair. My concern is to the Commissioner Health, Ministry of Health. I am standing here with the cry of the section in health called the private not-for-profit health facilities, especially the lower health units, and more so the health center tools. We really are in the system, and being in the system means we are trying to do all the statutory requirements to meet. And most of our health center tools, they meet the standard to be upgraded, but this is not being done. Year in, year out. We find that public facilities are being upgraded. I'm sorry if I'm saying this, but it's a concern. We are overwhelmed. We are trying to build, to make the structure. We are trying to bring in the human resources necessary so that we also qualify and serve the nation, because we don't segregate. We don't say this is from public, we don't treat. Any patient who comes to our facilities, we treat them. But when it comes to this, it is limited. Secondly, primary health care. We are not also benefiting. Majority of our health facilities, the low health units, are not benefiting from primary health care, including some of the health centers raised. And now we have the RBF that has come and is targeting the health centers raised. But we are overwhelmed. If we were supported by the funding, the partners, the implementing partners that take care of the health center trees, and if we were upgraded, we feel that even our performance will go up, because our data that goes to the district, they are well enough, they are good, the performance are good. So it's a cry, and this is what I am really pleading. I know most of the DHOs bear witness. Thank you. God bless you.
Thank you. Finally, RPC.
Thank you, Chair. All protocol observed. My name is Margaret Oreko Bonyo, the regional northern jailer. Good afternoon, members. Chair, I have 3 issues within 2 minutes. One is purely information giving. I would like to inform you that as Northern Region team of prisons, we have our regional referral health facility that is situated in Gulu main prisons within Gulu city. In Northern Region, we have a population of those voiceless of over 4,000 inmates, both women and men, including the accompanying children, placed in different facilities as per what the law required, or per where the law required them to be. I would like to concur with the presenter. Unfortunately, I have not mastered her name well. I would like to confirm that in prisons we have many challenges. HIV/AIDS is still a problem. We have inmates who come to prisons with such conditions. TB, you are aware, in northern Uganda, it's also one of the very places with a high TB prevalence, and we are not exceptional because those persons come from the community. We also have issues of malnutrition. Chair and members, you'll get surprised to hear or to note that we normally receive many of our inmates who arrive from the courts when already malnourished. We have a system of examining them to establish their BMIs, and normally it is below the normal. And then the other one is about mental health that I think was not clearly talked about. We equally have such persons in custody. And I would like to now say, as prisons, our health center 3 in Gulu main receive drug supplies from national medical stores. But I think because it is a health center 3, we don't have a voice of ordering for medicines that should cater for these inmates, because I'm aware they have the 2 systems that I have forgotten which one we belong to. There is a push system and pull system. So in one of those that you know, I'm not a medical personnel, I'm just a jailer. That is the category where we belong, and we are always at the receiving end. And I'd like to also inform you that other than the, because around our area of Gulu, we have over 2,000 inmates and staff and their families, together with the neighboring communities, who come and receive treatment from our facility. So I am just up to send our concern and request in form of recommendation that consideration should be made to increase on drug supply to our facility. Much as it is under a health center 3, but with its uniqueness, I think it is imperative that consideration is made to have those drugs increased. Otherwise, the rest of the issues, we are together, we're working very hard. I'd like to thank Regional Referral Hospital that has always supported us with our inmates. When we refer them there, they are treated well. But of course, challenges of stock out of drugs also has hit them like any other health facility. We'd like to appreciate them so much. We also like to appreciate them for the support accorded to us. And the last information is that people have been very worried about COVID-19, and up to today we are still worried. But I want to allay your fears that all our inmates are safe. In this 1 year plus, we have not registered any fatalities among us inmates and even our staff. So we continue to follow the SOBs, the Minister of Health guidance, and also our Commissioner General of Prisons guidance on issues of COVID-19. And I want to also say that it's very bitter and tough on us on the issue of malnutrition. Even when we say some of these people come with malnutrition, come when they are malnourished, he thinks it is our responsibility to make sure that we reverse the situation. And I want to say that is what we are really working very hard to do. And this weekend we'll have a regional meeting of the staff, officers who are responsible for the care of those inmates. And I want to say together we shall work hard to ensure that we deliver quality service. Thank you so much, Chair.
Thank you very much, RPC, with those wonderful submissions. Dear members, finally, we have come to the end of our session. I want really to take this opportunity to thank you so much for actually having lively audience and marvelous presentations from the presenters. As the session chair, I want to say that I request the organizers that they should really leave their doors open for the submissions and recommendations so that this will really help us in policy formulations. Because what had been given by the audience and honorable members who are following us online might not actually be enough. So I request that let the door be open for the submissions. Finally, we are actually going for our lunch. Then after lunch, we'll resume. And Michael, by the name of Okaka Geoffrey, will be the next chair for the next session. And I beg that he should really consider Dr. Drabin to give his presentation in the afternoon session. With all these, dear members, I thank you so much for actually being lively. May Almighty God bless you. Amen.
Thank you. Thank you very much, Chair. Can you put my microphone on there, please? Thank you very much, Chair. Thank you for chairing the session. Ladies and gentlemen, first of all, I would like to say thank you for your active participation. It has been very lively, very informative, very educative, and the experiences that you have brought from the region. That is very, very, very good. Okay? This is very, very good. I'm told that the time allocated for some of the presentations is a bit short, but also let us look at the other side of the coin. You knew that your presentation was 15 minutes, so tailor it to 15 minutes as well. You see? So that you can highlight some of the points that we have here, because others have also said by the time you're coming here, you should have had some mini presentations in your areas so that you can give us a good highlight. But thank you for everything that you've given us today. Number two is that you notice we're in two groups, two sessions here. This place has been a little bit, it's fuller than the other side. Let me just put it that way. But some of the questions you were asking here would have been best answered the other side. For example, you were talking about staffing, human resource. There was a good presentation on the other side on human capital development priorities and program implementation modalities. Some of these questions would have been answered on the other side by the commission at the other side. So you need to see how we can move up and about, as it were, so that we can pick out the points that we need. And then some announcements here. One, I have noticed that much as we're in breakout sessions, some of our participants have taken leave. We are saying, please, stay with us. Stay with us. You have been purposely chosen to be here because they know that this meeting that we're having right now is so important to you, especially you, the leaders here. RDCs, cows, you know, and so many of you, chairpersons. And so you see, the information you're receiving here is information from your centers. So please, it is important that you, chairpersons, whip them and let them be around, please. Let them be around with us. And then number two, the virtual participants. I told you we are here more than about 250 of us. Over 200 are participating virtually. The organizers at the desk are telling me that some people are leaving their stations, the virtual stations, and coming here. Let me say it in simple terms. It is not about signing at our desk here. You can sign where you are. Your registration is going to be appended and brought to us, and we shall notice all that. So I am now talking directly to those online. Stay where you are, sign up from there, participate from there. The link is available. We can even take your questions in from that point, okay? We are trying to improve on our virtual nature. It's now a time we are following anyway. So let us see how we can participate in that format. So it is not about you leaving your stations to come here because the number is limited here anyway, okay? We are trying to maintain our SOPs. We are going for lunch. Lunch is by invitation only. You have a coupon, you will access the lunch. I don't have mine yet, but I know I will be there. But make sure you get yours. At least me, I can shortcut the line, but you may not be able to. And we are lunch, it's now 2 o'clock. Lunch is strictly 45 minutes. We are here at 2:45. So please come back, but come back straight to your break room sessions as well, because the afternoon sessions are there. Like I said, the one here is chaired by the cow of Gulu. Mr. Kaka is here with us. He made a speech in the morning. And the one in the other room is by Ms. Cinderella Nena from UNFPA. She will be there to chair that session. So please, let it strictly be 45 minutes. We come back in, we finish up, so that by about 4:30, we are done. Thank you very much. Thank you, participants, for coming. Lunch is downstairs, where we had breakfast. But please have a coupon. and the hotel team that we had lunch served within the time frame allocated for that. It was very, very successful. Thank you for that. I know we are coming to the afternoon session. Normally, it is a very difficult session when it is warm and you've just eaten. But I urge all of us to be around, be attentive. Like I said, we have 2 breakout sessions in the 2 halls. Specifically for this hall, our session chair is Mr. Geoffrey Okara, the Chief Administrative Officer for Gulu, and the chairperson of COWS for the region. And in the second hall, ballroom hall, we have Ms. Cinderella Anena from UNFPA. Now you'll notice earlier that we had taken one presentation up to replace the presentation of Dr. Rabin Drab from UNICEF. I just want to note to the chair of this session that we are going to start with Dr. Jackson Amone first, the Commissioner of Clinical Services in the Ministry of Health. And it is after that we shall have Dr. Rabin Drabe from UNICEF. So you start with the Commissioner, Dr. Jackson Amone first. And it is 15 minutes as usual. And then you allow for discussions and recommendations that may come through. Immediately after that, we shall be coming to the close for today. But I'll tell you one thing, tomorrow we expect to hear quite early so that we start on time, okay? Tomorrow I expect to back here quite early so that we start on time. I mentioned 8:30. If we can all be here registered by 8:30 so that at 9 o'clock we start, that would be a very good thing. Now, I had earlier on mentioned about signing of the board. The board is here. This is the board I was making reference to. The 2 ministers have already signed. We are actually supposed to have signed in the presence of everyone, but we had to take the board to them. So we accessed them and they've already signed. But on this board, we shall basically have the director and the commissioners from the Ministry of Health. Please, you need to come over and sign this board even now, because I have a marker here. Please come and start. Dr. Jackson, other doctors, please, where are the commissioners here in this room? Because I'm going to call the other ones in the other room. And I also need to have the chairpersons or the representatives of the DHOs, the representative of the chairperson of the COWS here present, please come and sign. The representative of the chairperson of the RDCs of the region, please come and sign. And be mindful of your signature. The space is a bit... yes, please, other people, please come and sign. Where is the sanitizer? Can somebody bring for me? Yeah, please come over. Representative or the chairperson of the LC5 persons from the region. Okay. And also I need a representative of the implementing partners. Here, please, where are the photographers? Come and let me put this thing out clearly.
Should all be in black?
Preferably, because we shall take a picture of it all. You come and spray it. I need your picture. Yeah, you just pretend again. Continue. Okay. I don't need to yes, is have you, please, be kind of sharp, kind of sharp. Huh? You spray it, okay, good. So that's the chairperson of the LC5, chairpersons of the region, the chairperson of Kitgum, the leadership of the Chief Administrative Officer, sir. That is the cow of Gulu. Please come and sign. Representative of the RDCs. Yes. I had so many commissioners here. Where have they all gone to? They're still for lunch? Yes, RDC. Yes. Let her come. Annabelle, representative from Annabelle. Any representative from the UN or its agencies? The agencies are many here. I remember they mentioned your names. Annabelle, UNICEF or UNFPA. Who is he? Commissioner Scarp, you are supposed to be here, sir. Doctor, yeah, please take a picture. Sign again or pretend to be doing so. Okay. There are photos to be taken here. Doctor, you're welcome, please. Sanitize that. Representative of the IPs, the implementing partners here, anyone? Oh, please do. Oh, Chief, please. Chief, you can do that. Please come and do that. Stand. Okay. Yes, thank you, Chief. Thank you for that. DHO Emeritus, Dr. Paul. Please come and sign. Please come and sign. Dr. Paul Onek, please. Anyone from UNICEF here? Any space there that you see. UNFP. Doctor? Dr. Hillary Alima. Please come and append your signature, please. This is a board that is going to be shown as a symbol of your participation, signed by your representatives, okay? Dr. Hillary, please. Dr. Susan, I mean RDC Susan Akany, please come and sign. Where is the representative, the chair of the DHOs? I'm not seeing Dr. Janet. She's still down? Probably she's in the other room. Are we done? Let's, Madam, please come and sign, then we shall close this session. I'm not sure if my colleagues on the other side are listening. Here, Madam is here. Use this pen. It's a marker. UNFPA representative. Where is Cinderella? I don't think my colleagues just look for Cinderella on the other side. And UNICEF. Any representative from UNICEF, please. Ladies and gentlemen, as we wait for that, our afternoon session, like I said, has two presenters as well. Session chairperson is the Cow Gulu. Geoffrey Okaka is here with us. Please take your seat. And the presentations are from Commissioner Dr. Jackson Amone and Dr. Rabin Drabi, the other presentation that was earlier skipped. So we hope this time he will be ready to present online. So, Cinderella, please come and sign our board. Please sign our board. Remember, some people are taking your picture for that matter. Murray stops. Yes. Pictures, please. Anena, continue because he has to take a picture. Anena, first pretend, as it were. Okay, thank you. Murray stops. Yeah. Okay, perfect. 15 minutes presentation, 30 minutes discussion, and we shall come to close for today. Chair, the floor is yours.
Thank you. Moderator, members, you are welcome to this afternoon session. Okaka Geoffrey is my name. I'm the Chief Administrative Officer of Gulu. I will walk with you through these two sessions. I now have the honor and privilege to invite Dr. Amone Jackson, the Commissioner of Clinical Services, to come and take us through a presentation on clinical service delivery. Dr. Jackson. As he prepares to come, I would like to acknowledge the fact that Dr. Jackson is a senior officer of the Ministry of Health, very senior, and the two of us have had good friendship since those school days. Again, to remind ourselves, 15 minutes, then we have the next presentation, 15 minutes, then we go into discussions.
Thank you so much, Mr. Chairman. And sometimes it's good to go to good schools where you have OBs. And I'm happy to say the car was my OB, and we are all doing well. Thank you for that. Thank you for the school, to the school. Ladies and gentlemen, I want to say some of the questions which were asked in the morning could have been answered with a number of presentations that are going to follow. And it was indeed mentioned that a similar presentation on human resource was being given on that, in that hall. And Chair, I would request to give me some few minutes as I attempt to answer some of the questions as
Go
I
ahead.
make my presentation.
Yeah.
My name is Dr. Jackson Amone. I'm the Commissioner for Clinical Services. I'm in charge of the health facilities in the country, ranging from the lowest health center to the IS. That is the Regional Referral Hospital. Next. Is it moving? So this is just a brief outline of what I'm going to talk about. I don't need to labor about it. The next. I just put that photo to show that if you are talking about health, the road to health is like that. All sides are dangerous, and you really don't know where you're going. Can you see where that road is going? You may not see where it is going, but we want to go somewhere, and we are here now. How do we reach where we want to go? So the road to health is like that. Is very obscured. You don't know where you are going, but we know where we are. So it is important we know where we are, and we need to discuss where are we going. Next. So in defining this, I want you to understand what is the health system. There are so many definitions of the health system. It can be defined as all activities whose primary purpose is to promote, restore, or maintain health. That's the easiest. You can also go with a long definition as given by WHO, because it goes into the details of everything about health. But for this purpose, let's just limit ourselves to the first one.
Next slide. The national health system, which guides what we should do, is composed of about 3 important things. 1 is the public. 2 is a private not-for-profit, as Cesar has already mentioned. I'm not only a commissioner for public, I'm a commissioner for all this, apart from maybe the last one. The private not-for-profit, which are mainly faith-based organizations. The third are the private health practitioners, which sometimes they call them private for profit. And the last one, which I'm sure most of you also, can I remove this mask? Thank you. The fourth one, which I'm sure most of you have already attempted to use, is the traditional and complementary medicine. At least each of you have got that. Other local concoction, even during this COVID, many people went for this traditional medicine. So these are the 4 things which constitute our health system. And they are in 3 levels. If you are talking about the Western medicine, the primary, the secondary, and the tertiary, and access through the primary health care. I will elaborate on it a bit. But in case of emergency, you just go to any level you want. Next step. Next slide. Maybe you could remove the photo so that people can read. Is it possible? Yes. So this is what I was talking about, that there are 3 levels of care: the primary, the secondary, and the tertiary. And I've already mentioned those, that is composed of those 4 major things. And the community is very important when we are talking about health care delivery. And that is where we have the Health Center 1. But we also have Health Center 2, Health Center 3, Health Center 4, the general hospitals, the regional and national referral. And for a good service delivery, people must follow that order when you want to get services. But as somebody has said, people don't trust. You may have a health center too near your home, but you want to come to regional referral hospital. You may have a health center 4, you may want to come to the regional referral hospital. So patients are expected first to be seen at the primary care before being referred to the secondary and the tertiary. So that is a kind of thing that I will discuss later. Next. So what is the purpose, or what's the objectives of the primary for the health system? 1 is to provide services to deal with the existing problems through the best use of the available resources. I want to repeat, the best use of the available resources. As Minister of Health, the resources are already given. So the resources which are there are the one we are going to use it to the best of our ability. 2, to achieve a balance between supply and demand. The supply are the health workers. The demand are the patients. We have to meet that. Do we have enough health workers? Do we have enough patients to treat? So there must be a balance between these 2. So as we are talking about this, let's note that as we advance. The other one is we have a decentralized system. There's decentralization and centralization services. So when we are talking about human resources at the district, is it the responsibility of the center or the responsibility of the district? So when we know this, then we can know where do we address the issue. The other one is the cause and effect. If you have the money and you put it in that service, will it give what we really want to come out? You have that money, you treat the patient, will the patient get cured? And finally, there's need of greater flexibility of the whole system of the healthcare delivery, including referral. People have talked about referral. That is a thing we need to do. How do we have this greater flexibility on the service delivery so that we achieve what we want? Next. This is the health sector, which we talked about generally.
that we have the Minister of Health who was here, we have the Director General, we have the directorates, we have the regional referral, we have the district offices, we have the health sub-district, which contains the lower level facilities and the community health structures. When you talk about the health sub-district, many of you may not understand, but I'm happy the DHO Emeritus is here. He will talk about some of those things tomorrow. The health sub-district was a very powerful concept which somehow it died down. Doctor, you will talk about it. It is not mine. So attached to this, we have other players. Next. So we have the other, next before this. Yes. Attached to the main system, we have this semi-autonomous and autonomous institution like the Blood Bank, the National Public Laboratory Research Institution, while the autonomous one like the Cancer Institute, which was mentioned, the Uganda Art Institute, the professional bodies, the National Drug Authority, the National Medical Stores, and the academia and research institution. These are key partners which we want to work with. Next. And in addition to that, we work closely with our key partners, and there are many. I just mentioned some few. There are many bodies which are here that they work with us to deliver the clinical services that everybody wants to get. Next. So, what is the function of the Ministry of Health as a headquarters? These are what we do. Policy, analysis, formulation and dialogue, strategic planning, resource mobilization, standards, human resource capacity development, all this, that is what we do at the Ministry headquarters. Next. While we do that, I've already said, what we are talking about at the center is the centralized health system delivery with those autonomous institutions. But at the district level, we have a decentralized service that is done in line with the 1995 Constitution and the 1997 Local Government Act, which states the role of the local authorities to look at quality health service delivery, recruitment and management of personnel for the district health services, passing bylaws related to health, planning, budgeting, all these are supposed to be done at the district level. And the district level include general hospitals, Health Center 4, Health Center 3, Health Center 2, and the community. So I want to emphasize this so that we get to know what is the role of us here. What should we play if you are going to deliver a good clinical services? Next.
Doctor, you have about 5 minutes to go.
So these are the national health facility availability, that this is how the population that they should serve. Next. And at each level, we have the services that should be done. Our senior colleague from the prison services was talking about the Health Center 3. We want to see what at Health Center 1, what is there? Health Center 2, what is there? Health Center 3, Health Center 4. All these services has already been stipulated that these are the services related to the human resource and the equipment and medicine that should be given at those levels. Next. And it continues to the general hospitals, the regional referral hospitals, and the national referral hospital. Next. So these are what are supposed to be done at those different levels. If you know the level of the facility, the services which are supposed to be provided are geared to that. But these are not cast in stone. You can do anything slightly more, as the regional prison commander was saying. You can do something more, depending on the resources which you have. But these are the bare minimum that you should provide at that level. Next. So, in all, this is how we relate the health system delivery, or the health service delivery structure. Next. So, what is the role of the hospital where we deliver these services? The hospital provides these curative services depending on their capacity as the first referral center. So I'm happy to say people are asking for hospitals because they provide the service. They provide what people should. It's a first referral center. That's the hospital. From all these lower health facilities, the hospital should be the first referral. And they provide the emergency care for severely sick people. And then they are also center of transfer of knowledge. We train people in those, and they constitute the essential sources for information. And all these other things are done at the hospital level. And this goes depending on which level of hospital you have. Next. These are the hospitals we have in the country. The national referral, the regional referral, the general hospital, all this. And this includes both private and private, not-for-profit, and the public. So the total facilities that we now have is 7,426 in all the facilities in the country. Next. As we provide the services, we are also conversant that COVID-19 is with us, and that's one of the services we are supposed to provide. And the hospitals are training centers. They provide the training for the health workers so that they are aware of what they should really do. And the general hospitals have been screening these patients. The regional referral hospitals are the treatment centers, which we need to note. And it is important that all health facilities are to continue with provision of other services as we also look at the provision for treatment for COVID-19. Next. While we do that, somebody has already mentioned, support supervision is very key as we do this. And support supervision are done to mentor, to support, but we have three major types: the technical support supervision, integrated support supervision, and the emergency support supervision. So for each time we are doing any clinical work, we need to know why are we doing. And what we consider for the support supervision is already mentioned there. Next. Another area which I want to mention is the referral system. People should be referred, and you are referred for many reasons. And this is how we should do it. At the beginning, I mentioned that as you move from one point to another, you must exhaust the services at a lower level. And that's what they call the gatekeeping mechanism, which my colleague, the director for regional referral hospital, said many people come without exhausting the services which are below. So we need this gatekeeping to enable us use the services at the different levels well. Next. So we have two types of referral. Either you refer externally or internally. Externally, you can refer from one health facility to another. Or you can refer from this country to another country. That's external. But you can also do internal referral. Referral made within the same facility to consult. And that's mainly called consultation. Next.
You should be summarizing.
I'm going to summarize soon. Okay. So these are the principles of the referral. Why do we refer? These are the principles which everybody should be aware of, especially the health workers. Next. And the referral chain and flow. Sometimes people say, why do you refer to Lacho Hospital? From Gulu Hospital, why do you refer to Lacho Hospital? There are so many reasons why you should refer. We refer upwards, downwards, and horizontally. So when you refer to Lacho, there's completely nothing wrong with it. It is the reason why you refer to Lacho from Gulu Hospital, which is important. So we need to know all those. Next. And these are what you refer. You can either refer a patient, you can refer the specimen, you can refer the parameters of the patient, or you can refer the expertise. So referral in clinical services is very important. Next. We have many challenges, which people have already talked about, and that's what I'm going to summarize with, Honorable Chair. We have huge disease burden, owing to commonly in our document We have pneumonia, we have malaria, we have diarrhea, we have sepsis, pneumonia, anemia, especially in the newborn and children. These are the major disease conditions. But we need to note also that there are emerging and re-emerging diseases. COVID just came 2 years ago. If you are listening to radios around here, TB has come back. Leprosy has come back in this region. These are all diseases that we thought they had gone, but they are coming back. So, as we budget, there's a big, big disease burden. And then the budget increases, the budget increases for emergency, essential medicine health supplies are not tandem to the population. It has already been mentioned that as Ministry of Health, they give us money, but they are not aware that the population is growing. So these are issues that the politicians must take interest. If you look at the budget for Ministry of Health, we should be getting about 15% of the budget, the national cake, but we get about, it has been lingering between 7 and 8%. And that cannot make us achieve what we want. So the budget, the national budget, must be addressed as we talk about health service delivery. Our infrastructures are not good. When you go to some of the facilities, you'll find you may have only 1 or 2 accommodation for the staff. But you may say there are about 9 or 10 staff. Where are they going to be accommodated? So that is still a challenge for us. And in the morning, we talked about inadequacy in human resource. And this is at all levels, including some critical positions. And as I said, at the regional national hospital is a responsibility of the center. But at general hospital health centers is a responsibility of the district. As ministry, we noted that these structures of staffing is not aligned to the population. So Ministry of Health and Public Service have revised the structure. And they are now presenting it to Ministry of Finance so that they put in the wage so that we can functionalize it. But also, earlier on, the general hospitals already had very many positions which are not filled. And this is because we don't have the wage bill. You may have the position, but if you don't have the wage bill, you will not be able to recruit. Inadequate transport and funding for the district level coordination and support supervision. I've mentioned about support supervision. The DHOs are here. We work through the DHOs. We work through the regional referral hospital. My colleague presented in the morning, we have a new national guideline on support supervision. As Ministry of Health will not go to the district unless we go through the region. So the regional referral hospitals are now being empowered to be the one to lead in the support supervision. So they need all this support in terms of coordination, using the vehicles and other issues. Next. Inadequacy in the maintenance of medical equipment. It was mentioned in the morning that you go to Gulu Hospital, you ask for investigation, the lab, the x-rays, they say we cannot do it because we have equipment which are not being maintained well. And because we don't have the people to maintain, and you cannot do those investigations. And as the theme for this conference, there is an additional burden brought by refugees and the urban population health. We are asking for the city, but the city is coming with this problem. The urban health is a very complicated thing that everybody is looking at, and that will give us another burden of how to provide health services to our population. And finally, management of the virus disease outbreaks and the public health emergencies has been interrupting most of our services. You don't know how much money Ministry of Health has put on COVID. We have forgotten about other things. They were putting money on COVID. So when you talk about malaria, you talk about another health facility, you are talk about this, the direction is still on COVID. So these public health emergencies are also a threat to what we are supposed to do. I think this is what I intend to discuss.
Thank you.
With you. Last slide. When you see that, you know where the photo was taken. For some of you who have traveled far.
Members, can we
asking for
put
the
our hands
support.
together to thank Doctor
Thank
for the
you so much.
presentation. Doctor, there's a seat here for you. As we take note of the issues needing clarifications, but that should only be after we have got a presentation from Dr. Rabin Rabe. And that is, okay, you're most welcome. That is going to be on the status of functionality of general hospitals and health center force. And Dr. Rabin will be online. I hope efforts are being made to get him online. Dr. Rabin.
For us attending from elsewhere, we can hear you.
Yes, yes.
Yeah, we can see you, Dr. Rabin, and 15 minutes is for you for the presentation, and really the floor is yours.
vis-a-vis the travel time when a person is referred. You can see from the graph that in northern Uganda, you take 103. That is the mean. You take 103 minutes to reach a health facility. That means that you take over nearly 1 hour and 30 minutes to reach a health facility. And the average, the median is 60 minutes. So that is the challenge we are facing in assessing health facilities in northern Uganda. This is the the density, patient density for 100,000 people. You can see northern Uganda has got one of the lowest, it is 1.8. That means that the facilities are fewer than the population. The good center, a good region, geographical region in Uganda, where health facilities are easily accessible, is in the central region and western Uganda. You see, this is a map to demonstrate districts in Uganda with no health facilities. When you count the number of districts, you see in the northern part of Uganda, we have Amuro, we have Lamon, we have Pade, we have Otuke. Others are Amuria, Alepton, Kole, Dokolo, and Koboko. These are facilities, districts with no health facility. They essentially depends on the functions of health center 4. Quality of care. I want to skip this graph, but I'd like you to pay attention to this one. You see the OPD utilization at TIAC is 1.2. First ANC attendance is 88%. First trimester visit, you look at those color coding, which are in red. Those ones require urgent action, particularly in the districts, in the facilities of Atiak, in the facilities of Awach, Namkora, and Padibe. Mariupoi, the antenatal care, the first visit is above 50%. And Pajule, those are hanging below 45%. So I think my colleagues, my friends, the DHOs should look at this graph and analyze and dive deep to find reasons why, how they can transform this red color code to maybe a yellow or green from now up to the end of the financial year. This is the health system. I'm not going to go into this. Challenges of functionalizing health center 4.
Dr. Rabin, you have under 5 minutes remaining.
I will finish before that. Thank you.
Thank you.
Yes, human resource, particularly anesthetists, laboratory technicians. These are key to functionalize theaters. The issue of leadership management is also a challenge. When the theaters are constructed, they were awarded to contractors. Those contractors know how to build living houses. They don't know how to construct theaters. As a result, most of the theaters are not functioning. The issue of investment in training, the issue of motivation and retaining of staff. If most health workers, when they are posted to health center 4, it means that they have left the town where amenities are not there. The issue of infrastructure, logistics, power, running water, restriction on recruitment, which Commissioner has mentioned, all these are affecting functionality of health center force. Thank you very much.
Thank you, Dr.
Chair.
Rabin. Can we put our hands together to thank Dr. Rabin for the presentation? Thank you, Rabin. We still expect you to remain online, expecting areas needing clarifications and so on. So members, we go in for the component of discussions. I hope all of us are still within the house, and you will direct to whom the question is going. The floor is open. The floor is open. I hope all of us are still within the house. We are going to give this bit a maximum of 30 minutes. I was saying, I hope all of us are still within the house.
Chair, there is a hand there. David Ogwang who's put up his hand.
Chairman, can I ask my question?
Please, go ahead.
I'm Dr. Gwang from Lacho Hospital. I've seen the presentation and thank you for the presenters. I just have one question and maybe I declare my conflict of interest. I am a surgeon and I'm very much interested in the surgical services. I've seen that anesthetists are really without anesthetists, the health center for the surgical emergency surgical services cannot work very well. In this sub-region, we have 2 training institutions. And this is, I think, the College of Health Sciences in Gulu, and then Lacho Hospital. Is there a way we can support and sponsor those medical workers who want to specialize in anesthesia so that we functionalize these health centers for? And in this way, we might as well reduce the maternal mortality, because without, there is always this complication that will occur and that will need surgery. The second question is to Dr. Mone. I think the ministry is thinking in a good way, and I think COVID has brought something very interesting for us. That is critical care. I think these cadres, we need to look at them with a more, let us say, we have to look in detail on how we can deploy them. I think they are very, very necessary for emergency services. Where I sit, it's a referral, and most of the time, patients come when they're not even fully optimized, or fully resuscitated. So sometimes just somebody reaches when they're about to die. So I think let us spread the critical care services.
Thank you.
As far as emergency services. Thank you.
Thank you, thank you, thank you. It's clear. More questions?
Yes, Chair. This is Valentine. Can I ask my question?
Proceed, Valentine.
Yes, thank you. Thank you, presenters. Thank you, Dr. Mone from the ministry. I am Valentine Ojoro from AMREF Full Office. My interest is on issues to do with data management. We know most of the health facilities, they write the patient records on books, and it is hard to follow up the patient to track. I am well aware of the difficulties that Minister of Health is facing in regards to infrastructure development. But I would request Dr. Amone and all the stakeholders present, is the way we can migrate from using exercise books for collecting patients' data to either maybe a digital way so that it can facilitate us to understand how our patients are. For example, right now, if you wanted to do any study retrospectively to understand how patients react to this drug, to the other drug, We don't have that information, and I think that is a very big gap that the ministry is facing in the country. Thank you.
Thank you, Valentine. Any other question? Yes, I can see, and Charles.
Thank you so much, Chairperson and the presenters. I'm Charles Umar, the cow of Lamore. I have 3 areas for Dr. Jackson Amone. One, thank you for outlining very clearly the health systems in the country. At the bottom, it is the community, which you emphasized, but also the previous speakers talked about. And this lies with the VHTs. That name is voluntary. But if I got an earlier presentation right, the interest now is to move health service delivery away from the health facilities to the communities in the hands of the VHTs. But time and again, these VHTs have complained of their welfare. What could be the government intention to ensure that as we roll out to limit pressure on our health facilities, we also ensure welfare of the VHTs? Inquiry number 2 is about the autonomous institutions that you put them there, and you said you work with them, or government works with them. How do they directly link up with either your office or the ministry? At what point do they link? And you talked of decentralized and centralized structures. Where do you put them? Are they center? But of course, they are not part of us as local governments. So if they are not with you, where are they? The last one, Doctor, is the private for-profit health facilities. In the context of COVID, this country has suffered. I lost an OB who died from a private for-profit facility in Entebbe. He left behind a bill of 130 million Uganda shillings. And the extended family and the clan is trying to see how to offset. So how do they also hinge, and how are they regulated in this country so that everybody, irrespective of what you are or who you are, if you want to go there, then you are served, not exploited. Moreover, if you now lose your life, and that burden remains behind. Thank you.
Thank you, Charles. It has been noted. Any other questions? There is behind there, please. Then I will come to you. Right at the rear, please.
Yeah, thank you, the chair. My question is very simple. I wanted to find out how the government relates with the private health facilities owned by individuals. Is there any MOU as the partners?
It would be fair that you remind us with your name again.
Thank you very much, Chair. My name is Dennis Okelo, Gulu Regional Blood Bank. One of the issues raised as a reason for referral from Health Center 4s was lack of blood transfusion services at those facilities. I think this is a big challenge. I don't know how it's going to be tackled because most of these health center forces are not able to carry out these surgeries, most especially cesarean sections, because they do not have access to blood. And the reason they give is they do not have enough funding to be able to come and pick blood from the regional blood banks. What is the ministry going to do to ensure accessibility of blood, or maybe to make sure that blood, which is very critical for cesarean section and surgeries, is readily available at health center force? That was my question.
Thank you. There is a hand on my right here, this last line.
Thank you, Chair, for giving me the opportunity. My name is Acholi, the acting DHO of Lamour. The last time I interacted with the Commissioner, Dr. Mone, his prayers for me was to see me in that office. Doctor, I'm still there. Thank you. I would like to attempt to make a contribution to addressing some of the solutions, the challenges raised, especially on operationalization of the health center force. Dr. Drabe indicated the status by facility, and I am sure in the next room, UNFPA will also make mention of that in line with the CMOC. Doctor, you will agree with me that working at a health center for is not an easy thing if somebody has not put aside most of the things we enjoy around the environment. Putting that aside, I also want to appreciate that, yes, infrastructural design could be an issue, the way these theaters were constructed. But we can start from there and improve as we proceed. To me, Commissioner, some of our colleagues at this health center force would need additional support technically. And with the current shift at the ministry working through regional referral hospital, I would strongly suggest that our technical team from the regional referral hospital should make every arrangement, at least to identify those health center forces that are most in need of technical support and work with them accordingly, especially in the area of CMOC and some of these emergency general operations. This is a suggestion I want to put forward. And as we do that, we'll also engage with partners to see that we operationalize those facilities accordingly and we serve our people. Thank you.
Thank you, Doctor. I think, yes, the one in orange. And we should be coming to the end. Okay, then, okay.
Thank you very much. My name is Joseph Barijuka. I'm the pharmacist regions for National Medical Stores. There are some questions I've had here, but probably shall come to that later. Mainly, this is to Dr. Mone. We've talked about improving services in the health facilities. That is when it comes to increasing the human resource, increasing some of the infrastructure in these facilities. But most of the time when it happens, especially when they're upgrading facilities, they usually forget about the stores for these essential medicines and health supplies. You find a health center 2 is upgraded to health center 3, but the store remains at health center 2 level. So they don't really have capacity to handle the supplies that we're going to give them as NMS. This is one in terms of infrastructure, that is the size of the stores, the shelving. Most of them that have gone to as part of our usually support supervision visits, you find most of them do not actually have cold chain refrigerators for their cold chain items. That's for the lab items and cold chain items like oxytocin, insulin at the health center 4 level, things like that. Then also have to advocate for the infrastructure, the human resource. You find most of these stores don't have dedicated personnel to them. I would like to advocate if it's possible, we can at least get pharmacy technicians in the health center 3s, health center 4s. At least it will be easier to handle issues of medicines, medical supplies, and management if we have technical personnel in those facilities. Thank you.
Thank you. We come finally to Dr. Onek, DHO Emeritus. Doctor. Meanwhile, Dr. Rabin should be getting ready for response.
Thank you, Chair, with your OB. I don't know where to direct this question to, because some of the issues we are discussing now actually should have been, our members of parliament should have been in attendance. I hear they make a lot of noise in parliament, but this is where they generate the true issues. Since I was in service for very many years, over 40 years in the health sector, the budget for the health sector has not exceeded 10% of the national budget. The minimum government recommends is about 15%. We have hardly exceeded 10%. Now, we are receiving now about 7 to 8%. Out of that, I would like to know. So, the MPs should be here. If they can come tomorrow, if they can't, next time. So out of what we receive, could I know how it is distributed between Ministry of Health headquarters, the regional referral hospitals, the institutions like the blood bank, and what really trickles down to the district? What is the percentage which trickles down to the district? If we don't know that, then as Dr. Mone said, we don't know where we are going. The idea is primary health care is the priority. But if we are still continuing to refer jiggers from the community to a regional referral hospital, we are not making any progress. And we really need to address primary health care seriously from the individual, the household, and the community. Then we shall get rid of some of these things. Otherwise, we are just playing around with words. 10 years later, when I'm dead, you will still be talking of 15%. We are only getting 7 to 8%. Who can put the feet down and say health must now get 15%? Thank you.
Thank you, Doctor. I think we come to the end of the questions now, and it's just fair that we get responses. Dr. Rabin is online, and it is fair that we give him the chance to respond, I think, to the first issue which was addressed to him. Dr. Rabin.
Yes, thank you. Thank you, Mr. Chair. I have two concerns that were raised to me directly. One is the issue of human resource, critical cadres of staff that are supposed to be in a health center in order to operationalize it. I did not show it to the group, but when you look at the cesarean section rates in Atiak, in Awach, in Namokora, in Mario Pay, in Ipajule, they are really, really miserable. Actually, it ranges from 0 to 0, 0.0 to 1.7. This is because these facilities do not have anesthetic officers. I think DHOs have got they have got their master plan for human resource development. Dedicated staff can be isolated, can be identified, and they can sponsor them to go and do this anesthetic course, so that when they come back, they're able to operationalize the theaters. Two, the question of health sector budget. You know, heads of states went to Abuja. They make the declaration that the budget for the health sectors will be 15%. I was calculating monies that are sent to the district for medicines. This money is allocated maybe to Gulu district, but they're not called to Gulu district. It stays with the center. When you calculate the per capita drug expenditure, is less than 2,000 shillings per person per year. So that's why when they see the national drug medicines coming to the district, the following day people will line up in the health facility to get the medicine, so that when they get sick, they can take the medicine. On the functionality of health center force, there's a question from the acting DHO of Lamont. I cannot agree with you more than what you have said. I think we need dedication. Two, we need to support the young colleagues left the internship. When they are posted to this health center for, sometimes they get a challenge. In West Nile sub-region, we got a senior colleague to be attached to that health center for a period of 3 months to build the capacity of the young colleagues who have just graduated from school. Because it has been found out that the rate of sepsis, rate of maternal mortality morbidity following cesarean section has increased in that health facility. And therefore, after clinical mentorship, we were able to see a decrease in the rate of maternal morbidity and pregnancy outcomes. I think, Mr. Chair, that is what was directed to me. Thank you.
Thank you, Dr. Rabin. You can still stay online with us. I now invite Dr. Jackson Amone for responses. Doctor.
Yeah, thank you so much, Chair. I have some few questions. If time allows, I will also answer some of the questions which were raised before lunch. Members, what I want to say is that as Ministry of Health, we are very much talking about the community. And I'm happy my colleague, so you are being given coupons before lunch. Not so. Somebody bought for you the lunch. Without that, you would not eat in the restaurant. And I want to emphasize again that your health is your responsibility. It is not the responsibility of any person. We have to take it seriously. So we need to contribute to our health. And that's why the Ministry of Health was really emphasizing that we need to bring in place the national health policy, the national insurance policy, so that each of us will pay for our health. Some of you are a bit better. You will pay for those who don't have. And it will try to add on to what government is paying. Because if we leave our health in the hands of government and we begin lamenting, we don't have drugs, how much have you paid for your health? That's the first thing we need to ask ourselves, how much have we paid? And sickness comes at the point when you don't have money. And that's very unfortunate. I want to answer the question, the first question from Mr. Martin Ogwang. I think the first part was already answered. I want to say that as ministry, we are working with the academic institutions, and we have opened many training courses for people who give anesthesia. There are diploma courses and also degree for anesthetic officers, which is being offered at Busutema. So there are many places who are training now those cadre. But the suggestion Dr. Guang gave is also okay. If district can sponsor people to go and do these courses, then you are sure of having an anesthetic officer. So we need to look at that. The other part, which is critical care, is really important. We had not been talking about it because many people were not going to where they needed the critical care. The intensive care unit is a very expensive venture that even the private institutions, they were not doing it until COVID came because they saw some money was coming in. Ordinarily, to have a patient in an intensive care, be it any place, you have to part with about 2.5 to 3 million. And it is cheaper in Uganda. I was privileged to go to Aga Khan in Nairobi. They'll never allow an ICU bed to sleep empty because there's a loss of revenue. And the demand is so high. So it is not that it's being over-exaggerated, but that is a cost. Because you may have a one-to-one, one patient, one nurse, one patient, and you may have more than one because you may have a critical care nurse, you may have an intensivist who is a trained doctor, and then you may have these other people running around. So you may have 4 health workers looking after one patient, depending on how serious the patient is. So the cost of critical care is very high, and he was right to say it has an eye-opener to government. And because of that, we are now opening other training. They have been training nurses for critical care. There are emergency doctors who are being trained in Makerere and in Barara, so that when they come out, they will be recruited. And government, Ministry of Health is now prioritizing some of this. They are going to offer scholarships for people who want to do critical care, nursing, and intensivist training for the health workers. So those who are interested can be trained in those areas. The issue of data management. As ministry, we have seen the problem of people moving with papers. Because whether you have a medical form 5, it is very rare that you'll keep it for 6 months and you'll go back with it to the health facility. So the policy of the Ministry of Health is to have what they call paperless hospitals. You go to the hospital, they take your details. Anywhere you go, that same detail is what you will need. All what you need to go back to the hospital is to have your identity, maybe a number. So that you go to the hospital, say, I'm Dr. Amone. They enter your name, they say, you were here 2 months ago, this was your problem. So if it is the same problem, they continue giving you treatment. And if you are within the hospital now, you go to the lab, everything will be there. You go to the X-ray, everything will be there. And they will relay that to the doctor, and the doctor will see you. So you don't need any document. And the only thing you need is a prescription for the medicine that you will get. And those prescriptions will also be entered into the system. And you go to the pharmacy and you get your medicine. And we want to link that information. If you are in Gulu Hospital, you can be referred to Arua Hospital, you can be referred to Mulago. And the referral system will be now online. So that before you go to Mulago, Mulago would have known that we are referring a patient from Gulu or from Lacho to Mulago. And they will prepare for you. So there will be a lot of learning and consultation within the system. And as I mentioned, that there are so many things that you can refer. Either you refer the patient, you refer the specimen, you refer the parameter, or you refer a specialist. So all those referrals can now be done if we go on, we digitalize our medical records. The issue of VHTs is a very fluid issue that for now, each village is supposed to have 2 VHTs, and their welfare is not very clear. You remember at some point the ministry thought, since the VHT, some of them are not well educated, others may not know how to read and write. We brought an issue that the lowest level of health workers should be the community health extension workers, but we did not succeed in bringing that into policy, because they wanted those people to be recruited and they will be trained, and then each village would nominate the person that should be trained. And we had even put that in our budget, but somewhere it was shut down. But we are still looking at it. And those are the people who we had put a budget for them, that once they are trained, they'll be on salary and will be paid on a monthly basis. And they'll be accountable to the people who supervise them. But because of the VHT, the reporting system is not very clear. I don't want to dwell so much in discussing them because they may not fall under my jurisdiction. The other issue which I talked about, the autonomous institutions. The autonomous institutions are institutions that from finance and they account directly to finance. They are not accountable to the Ministry of Health. And that's why I say they're autonomous. They have a very good working relationship with Ministry of Health. Their policies are all under the Minister of Health. But in terms of funding, they get their own money and they account for their own money. Like Uganda Heart Institute, I happen to have been one of their board members. Hey, there's a board member around. Where is Dr. Yo? He's in the other room. Dr. Yo is a board member. He replaced me in the Uganda Art Institute as a director. They decide everything. They have an act of parliament to set the Uganda Heart Institute, the Uganda Cancer Institute. They do their own thing. They do their own recruitment. So they are autonomous in that everything that they do, they decide on it. But they are still accountable to the Ministry of Health. So in terms of policy, they are under the Ministry of Health. In terms of resources and how they do their work, they are autonomous. The private health practitioners, you know, we are in a liberal economy. If I get out of here, I set my hotel, I'm the one to decide how much I should charge you to sleep in that hotel. It is business. And even these private health practitioners, they are doing business. And in health, we say a patient vote with the feet. Dr. Dong, you know it. Dr. Unek, you know it. The patient vote with their feet. They decide where they go. If the service is not good, you don't go. You put a sign of a cross, you pray to God to let what this is 10,000, this is 15,000, depending on where they are made. So these are realities which you have. And the Ministry of Health, because of the money we don't have, we talk about the minimum health care package. Minimum health care package. We are not going to the most expensive, but the minimum. And even the minimum, we may not be affording now. But we are striving to give with the resources we have. That's what I was saying. The resources we have vis-a-vis the services we are giving. So let's look at that one. Blood. In the medical school, we were trained that never take a patient to theater without blood. And that's a policy. Never take a patient to theater without blood. I'm sure Dr. Martin knows this. He's online. But we risk sometimes to do it. You go to a health center for the mother is in an emergency. You want to relieve the mother and deliver the baby. you don't have blood. Blood will never be bought. Blood comes from us. If you don't donate, you'll get no blood. Arrangement, I was consulting because before we came, we consulted ourselves that let's go and talk in this assembly. That's why I'm talking about my commissioner, community health, commissioner non-communicable diseases, the commissioner for human resources, and the commissioner for standards, accreditation, and patient safety. We are all here because we wanted to communicate. Unfortunately, the commissioner for health infrastructure was not invited. And he had a lot of things to talk about, issues to do with infrastructure. But because he's not here, I cannot really talk much. But drugstore and the cold chain system is hospital. Currently, the health center 2 is supposed to have 9 staff, for which there's not supposed to be a clinical officer. There are supposed to be nurses only. Health center 3 are supposed to have 19, to be aided by a clinical officer. And health center 4 to have at least about 49 staff, to be aided by a doctor. But in the new recommendation, we want a doctor to go down up to health center 3. So that at the health center 3, you have a doctor. At health center 4, you have more doctors. The medicine, by the way, medicine is like money. When he's talking about the drugstore, that is the store for money. The store for drugs must be very good. So we want also the people who are going to look after the drugs at those different levels, which has already been catered for. And the discussion was done. I'm sure some of the district participated in the discussion. The DHOs are here. Some of you participated in the discussion. As ministry, we had a workshop in Jinja where we called all the regional referral hospitals to come and help us give their view, what they think is proper, which is a proper staffing for a regional referral hospital. To our surprise, what they came out was twice what the public service came out with. And we even laugh at ourselves because the money was not enough. So for now, we want to compromise those positions, submit it to finance, and see if they have the money. Then they will present it now to cabinet for approval, and that is what is going to be used. But human resource is a big issue. But other things were also mentioned, that whether the staffs are there, there's also absenteeism. The absenteeism are issues that are management issues. Chair is saying I should summarize. I want to say, in all our health facilities, in terms of management, the ministry has recommended a management committee or a management board. The management committee and the management board are the eyes and the ears of the community. If the community are not getting the services which they need, they should complain to the board. And the board or the committee will now answer. And the committee can report directly either to the COW for the lower facilities or for the regional referral hospital. They report straight to the Minister of Health. I think these were the questions which I was asked, but I would like to ask Chair, if you can allow me answer one or two, which was asked to my colleague, and he was not given time to answer.
Okay, proceed.
And if you can also give him time, because some of these things, that's why we have come to discuss them. So if we can discuss, we may answer some of the questions which were asked in the first presentation. I want to begin with the question which was mentioned, that our policies are outdated, especially in the issue of human resources. I've already mentioned that. The issue of stock out was well talked about. People get drugs and they go and stock it And the drugs you take at home, if it stays for 2-3 weeks, it is useless. It will not be effective because the environment where you keep the drugs is not what my colleague talked about. The store for drugs is different from the house where you stay. So let's avoid that. Let's communicate to the community, tell the community, you only go and get drugs when you are sick. If you are not sick, the chair of Pade district talked about a district hospital of Pade. And I think the idea was, you know, in the upgrade of a health facility, the discussion begins from the district council. The district council must discuss, and once you have discussed, and that's what is taken to the Ministry of Health, and you take it with the evidence. But they should have got maybe a hospital long time. I think the issue of creating a health center too at the district headquarters, leaving Pajule, I think that's what might have delayed. But Pajule would have been a very good place to be upgraded into a hospital for about 2-3 reasons. One, they have the land. Two, they have already some infrastructure. Three, they are on the highway. If you talk about upgrading a facility at the highway, that is for the emergency services. It's not only serving per day, but it's serving everybody who is going to travel along that. So I think you have a point, but you only need to put it clearly, and the ministry will look at that. The other issue which I think may need answering or just commenting on is what my colleague from World Vision talked about. Participants, I want to tell you that the biggest problem that we are going to face is going to be the teenage pregnancy, which is everywhere. Our children, our daughters, our grandchildren got pregnant. Some of them is not their making, but because of this COVID. We need, one, to accept that we have it as a problem. Two, we need to support them. If we don't support them, the repercussion is going to be very big, because these are young girls who are not prepared. If you don't support them and they don't attend antenatal, they will go to the health facility very late, and then they have a obstructed labor. One, they may lose their life. Two, they may lose that pregnancy. And three, they may lose the pregnancy and they end up with what they call obstetric fistula. Mothers who are unfortunate will be leaking urine, leaking feces, or leaking both. We need to avoid this. It's good he mentioned it. It's a problem that the community should address. And I think the leadership are here. Let's talk about it. If we talk about it, then it may become lighter. The last thing I want to comment about, there are many issues. I think my colleague, if he has what to say, will mention. When we are delivering health services, we want to try to avoid duplication. I know we have both the public, the private not-for-profit, and the private for-profit. If already we have a good health facility, if we want to put another one, should be far from the one which is already existing, if government is supposed to support all of them. So the siting of the location of a health facility is very important. And especially now, we have been upgrading the health center 2s to health center 3s. But we may be lucky to get some funding to upgrade health center 3s to health center 4s, or some health center 4s to a general hospital. If we get that funding, the district should really decide carefully, because they cannot come and say, today we are going to upgrade Chuar Health Center 3 to Health Center 4 without the recommendation from the district. Everything is done through the district, and we want to say when the construction is going on, it will delay if the district doesn't supervise. It is your responsibility to supervise those buildings and make sure the constructor work at the speed which is recommended. And once it is done, you can recruit the staff, and then with us what we do. Some of these facilities, they have money for equipment and medicine to come at the same time. Chair, I want to thank you. Thank you so much for allowing me to take that time.
Thank you, Dr. Jackson. Thank you, Dr. Rabin. Can we put our hands together to thank the facilitators? Again, can we thank ourselves for the active participation? I think with this we come to the end of our tasks here.
It's safety. Already my senior colleague, DHO Emeritus, had lost his phone in the earlier session. I'm not sure if you have recovered your phone, sir. Yes, he has. Thank you very much. So please do not leave your valuables here with us. Members of the protocol and the M&E committees, you're required to remain behind for a small meeting. They're requesting you to remain behind. So please, tomorrow, 8:30, we shall be here and we shall start. I'm also reminding, I think it's the DHO of Omoro, or part of the Secretariat. You're supposed to be giving us a recap tomorrow, so you have about 12 hours to do that. Put something right for us tomorrow of what transpired today. So we shall start with your presentation, and then we shall go ahead. Session chairs, please be available tomorrow. We don't want to have a mishap, and time will be of the essence for us. Have a good day, ladies and gentlemen. See you tomorrow morning.